right, good.
I
Thank you.
just need, if,
Before we get started, do you have any extra time? We yield it to Dr. Burgess.
okay. Is that a boat day on the 11th? So it must have come back on the 12th.
Subcommittee will come to order. Chair will recognize himself for an opening statement. I would like to thank Secretary Burwell for appearing before the subcommittee to discuss the administration's FY 2016 budget requests for the Department of Health and Human Services. Earlier this year, Madam Secretary, you stated that, quote, the hallmark of effective leadership is instilling a culture of transparency, ownership, and accountability, end quote. These are all laudable goals, and I appreciate your verbal commitment to these principles. However, your department's actions have failed to adhere to the same standard. For example, we have only heard silence from the White House on how the administration is preparing for an adverse ruling in King v. Burwell. We did receive a reply from you, and I thank you for that courtesy. But your letter contained no substantive answers to our questions. During your testimony to the Senate Finance Committee, you were again asked about the administration's plans, and again you repeatedly declined to provide a direct answer. And you know, this is not the transparency that we had hoped for. Understandably, we were very frustrated with the administration witnesses artfully dodging the questions that we ask here. And so I'm asking you today, please let your guard down a little and give us direct and complete answers to our questions. In 2009, the President correctly said, quote, the real problem with our long-term deficit actually has to do with our entitlement obligations, end quote. Since then, we've had the Simpson-Bowles Commission, a supercommittee, sequestration, and a government shutdown. And never once in all this time did the administration propose a plan to get the nation's fiscal house in order by recommending reforms to entitlements. The 2014 Medicare Trustees Report, which you signed, tells us that Medicare will be bankrupt very soon. We recently had Senator Joe Lieberman and former OMB Director Alice Rivlin here, and they told us much the same. And we stand ready to do the hard work of saving and strengthening Medicare. But we need a willing partner. Once again, the President's budget fails to propose serious entitlement reform. The proposals in the budget related to Medicaid amount to saving just 15 days worth of program spending over the next 10 years. The plan apparently is to let Medicare expenditures continue to grow without any of the structural reforms needed to strengthen and save this critical program. And this is not taking ownership. If we're going to save and strengthen our safety net programs for the most vulnerable, we have to do better than the President's budget. Both parties have to work together. You, we, the President need to work together to save our entitlement programs, make them sustainable. So we ask that you please work with us. On another subject, you may also remember that in early November of last year, we spoke on the phone about why HHS has so far failed to hold California accountable under federal law. As you know, on August 22nd, 2014, the California Department of Managed Health Care, DMHC, issued a directive mandating that all plans under DMHC authority immediately include coverage for all legal abortions. This is in direct violation of the Weldon Amendment, a civil rights statute that prohibits federal taxpayer funding for federal agencies and state or local governments that discriminate because a health care entity does not pay for, provide coverage of, or refer for abortions. What California is doing is clearly illegal. It is also morally wrong and violates the fundamental principles of freedom and conscience that our democracy is founded on, and it is your job to stop them, and so far that hasn't happened. so I'll have more to say about this when we get to the questions. In the meantime, Madam Secretary, we look forward to your testimony. We hope that you will stay to answer all of our questions, and with only 5 minutes of questions per member, we respectfully ask that you keep your answers concise and to the point. And Dr. Burgess, do you want the remaining time?
Thank you, Mr. Chairman. That's very kind of you. And Secretary, thank you for coming to our humble little subcommittee. I am frustrated over the administration's lack of transparency and the ability for Congress to get information that realistically we've been asking for the last 4 or 5 years, but specifically around ACA created entities, the Center for Medicare and Medicaid Innovation, the Prevention and Public Health Fund, the the Office of Consumer Information and Insurance Oversight, and the Patient Center for Outcomes and Research Initiative. Year after year, they have failed to achieve their mission of reducing healthcare costs and improving quality. We can't hold them accountable if we don't know how you're spending the dollars. So you and I have talked about this, and I do look forward to your responses in being able to finally get that information regarding those agencies under your
thanks,
purview.
gentlemen. Now I recognize the ranking member, Mr. Green, 5 minutes for opening statement.
Good morning, and thank you, Secretary Burwell, for being here today to discuss the President's FY16 budget proposal for the Department of Health and Human Services. A budget is more than a line of items on a page. It's a reflection of the priorities of our country. Our commitment must be to protect the progress that we made and to make strategic investments so that progress will continue in the future. This year marks the 50th anniversary of the creation of Medicare and Medicaid. Since the Children's Health Insurance Program was created to ensure America's children have insurance, most recently, Congress passed the Affordable Care Act, dramatically expanding access to health coverage and high-quality care. The Affordable Care Act took historic and significant steps toward laying the foundation for a better and more efficient health care system and expanding access to cover for millions of Americans for whom it was previously out of reach. It's also took important steps to restore the fiscal solvency of our health care system. According to the most recent estimates by the Congressional Budget Office, the Affordable Care Act will reduce the deficit by more than $100 billion for the first decade and by more than $1 trillion in the second decade. As we have seen through the second enrollment period, the Affordable Care Act has already succeeded in ensuring every American can have access to high-quality, affordable coverage. Thanks to the ACA, nearly 30 million Americans got covered. These are people who would otherwise be uninsured. We have made great progress, but the work's not done. I thank the agency for implementing the landmark health reform law and continuing to work with us so that we can build on these successes. In addition to prioritizing essential services and programs, I was pleased to see that the budget makes strategic investments to improve our health care system and clear the way for the progress into the future. This includes funding to support training of the next generation of healthcare providers, national preparedness against threats to public health, biomedical research, drug safety, and mental health services. The budget invests in community health centers to support the care that provide for 22 million patients. In their role at providing an accessible, reliable source of primary care in underserved communities, health centers will continue to be a critical element of our health system. The President's proposal takes a critical, important step by including 4 years of funding for the Children's Health Care Insurance Program. Currently, more than 10 million children get health insurance through CHIP. Additional funding for CHIP must be authorized so that there is no disruption in coverage and the states are able to continue operating their programs. The budget proposes to increase NIH funding. Since its creation, NIH has fostered remarkable advancements in human health, but for the past decade, NIH has suffered inadequate funding. Without significant funding increases, the U.S. will lose its status as a global leader in science and innovation. Additional resources will help defeat our nation's most harmful diseases and ensure that the United States continues to lead biomedical research and scientific breakthroughs. The budget proposal strengthens national preparedness for threats to public health, including naturally occurring threats and deliberate attacks. It also includes funding to reinforce our nation's ability to move quickly to detect infectious disease outbreaks through a new advanced molecular detection initiative, maintaining strong expertise at the Centers of Disease Control and Prevention. These are just a few highlights of what is included in the proposed HHS budget. I look forward to hearing more about the administration's proposal during today's hearing. Thank you, Madam Secretary, for joining the committee and to discuss the HHS budget. And if someone would like about 1:20 seconds, my colleague from California, Ms. Matsui.
Thank you very much for yielding me time, and welcome, Secretary Burwell. I appreciate the goals that the President and you have laid forth in the fiscal budget 2016 Department of HHS Services budget. Building on the improvements made by the Affordable Care Act, we are seeking to move our nation's health system by rewarding volume and forgetting about the waste business. So what we try to do this is working to achieve the triple aim in healthcare: better care, better outcomes, and reduce costs. We do this by making health insurance more affordable, by emphasizing prevention and public health, by encouraging scientific and clinical research, by taking advantage of the benefits of technology, and building up our nation's mental health system. Many of the proposals in the budget find savings in the Medicare and Medicaid programs by streamlining processes and realigning systems to ensure that patients get the right service at the right time. The budget would make the SGR fix permanent, which we need to do to provide stability for doctors and for seniors and people with disabilities in the Medicare program. The budget would also extend the Children's Health Insurance Program, or CHIP, that provides much-needed pediatric coverage to our nation's children. To conclude, I want to emphasize the Affordable Care Act is working. Over 11 million Americans signed up this year, including 500,000 in California alone. The administration just announced that since the law was enacted in 2010, 9.4 million people with Medicare have saved over $15 billion in prescription drugs. This is what we set out to do, and I appreciate working with you as we move forward. Thank you. Yield back.
Gentlelady yields back. Chair now recognizes Chairman of the full committee, Mr. Upton. 5 minutes for opening statement.
Well, thank you, Mr. Chairman. Secretary Burwell, welcome. Today marks your first official appearance before the Health Subcommittee, but I know that this is not your first time in this room, as you participated in one of our 21st Century Cures roundtables last year, and we very much appreciate that participation. Your testimony does come at a very pivotal point in health policy, from our exciting cures efforts to next week's Supreme Court oral arguments. We look forward to hearing the administration's perspective on the many important issues facing the American people. You have said during your tenure at HHS that transparency, ownership, and accountability are important values for the department to demonstrate, which we certainly welcome. In that spirit, we look forward to gaining straightforward answers here today about implementation of the President's health care law. There has been quite a few red flags raised in recent weeks on the continued struggles to implement key pieces of that health law. Just in the last week, 800,000 households learned that key tax forms sent out by the administration contained major errors. Those Americans were asked to delay tax filing, therefore also delaying their refunds. A recent analysis from H&R Block estimates that the majority of Obamacare customers are being forced to pay back some of those subsidies. Millions of Americans are also learning about the law's IRS fines for failing to comply with the individual mandate. The backlash has been so intense that the administration has resorted to yet another special enrollment period to quell some of the anger of those who are just coming to learn about the individual mandate penalty. And this last week, the healthcare.gov CEO Kevin Cunahan suggested that the back-end functions of the exchange would undergo a 2-year development plan. That means that this key part of the law will not be fully complete until President Obama leaves the White House. Collectively, these revelations suggest that the health care law is still not working. Our constituents deserve better. We know that. That is why I've worked on introducing the Patient Care Act, a health care reform blueprint. With my colleagues in the Senate, Chairman Hatch and Mr. Burr, I look forward to working with my colleagues about these ideas to improve health care in America by empowering states and families, not Washington. Yes, we have concerns with the President's signature law, but there are other important health care areas that we believe are fertile for collaboration. For the past year, almost year and a half, this committee has undertaken the bipartisan 21st Century Cures initiative to accelerate the pace of the discovery, development, and delivery of new treatments and cures for American patients. I would like to thank you for your personal engagement on the 21st Century Cures initiative. As you know, this is a top priority for our committee this year. Patients and families in my district in Michigan, as well as across the country, are looking for hope, and that's what we seek to instill. And this effort is also important to many job creators, as well, whether it be Stryker, Parago, or Pfizer in Southwest Michigan. I also want to thank the staff throughout the administration, particularly at the FDA and the NIH, for their work, their time, and effort to help us improve the ideas released by our committee at the end of last month. We've established a very good foundation, I think, for bipartisan success, and I will yield to other Republican members on this side. Seeing none,
time?
yield back.
Chair, thanks, gentlemen, and now recognize the ranking member of the full committee, Mr. Pallone, 5 minutes for opening statement.
Thank you, Chairman Pitts, and welcome, Secretary Burwell. Thank you for being with us today. Today, we're going to hear about the President's fiscal year 2016 Health and Human Services budget proposal, and there are many important provisions in the President's budget that we in Congress must work to support. I was pleased to see that the budget proposed a funding increase of $1 billion for the NIH. Investing in early-stage basic research is one of the most promising ways that we can accelerate the discovery of new treatments and cures. And support for NIH is critical to building our economy as well. Every dollar of NIH funding generates over $2 in local economic growth. Yet we have let NIH purchasing power decline by over 20% since 2003. And that's why finding a way to significantly increase funding for NIH will be my top priority as the 21st Century Cures initiative continues. I was also pleased to see that the budget fully funds a 4-year extension of the Children's Health Insurance Program, or CHIP. We must act on this proposal immediately, with more than 4/5 of state legislatures adjourning by the end of June. Lack of action and clarity from Congress will make budgeting and planning virtually impossible. By every measure, CHIP has become enormously successful and always has had strong bipartisan support. So extending CHIP funding should be the top priority of this committee to ensure consistent coverage for the millions of children who depend on this program. And I think we can all agree that no child should be left worse off because of the actions or lack thereof of Congress. The budget also adopts the framework of the bipartisan bicameral SGR repeal and replace legislation that Congress agreed to last year. I believe that because the sustainable growth rate is the result of a budget gimmick, and we already spent $169 billion paying to fix the problem, that offsets, especially those within our health programs, are not necessary. And if we must include offsets, the war savings, which are known as the Overseas Contingency Operation Funds, could be used. I know some on the other side of the aisle don't share this view. What I do hope is that we can agree that first, SGR should not be paid off for the backs of the beneficiaries. Beneficiaries will already pay for their share of the cost of SGR repeal through higher premiums, and half of all beneficiaries live on less than $23,500 per year. And that's why some of the proposals in the President's budget concern me. The President's budget proposes to further increase Part B and Part D premiums, increase the Part B deductible for new enrollees, and impose a new surcharge on the Part B premium for beneficiaries with certain Medigap policies, and also institutes a $100 copayment per home health episode. And this increases out-of-pocket costs on beneficiaries, and I think that we've seen enough of that. Beneficiaries may forego necessary services and as a result use more high-cost acute care services, and such policies will disproportionately affect lower and middle-income beneficiaries who are not poor enough for Medicaid nor have access to employer-sponsored retiree health care. So I urge the President and my colleagues to be extremely cautious when proposing cuts to Medicare and consider their impacts on our seniors. The last thing I wanted to mention is, well, first to commend you, Secretary, for your agency's hard work implementing the Affordable Care Act. Because of your efforts, 19 million uninsured Americans will be covered in this year, 2015. And I recognize the challenge your agency faces in implementing this law with limited resources. However, despite what I call Republican obstructionism, the Affordable Care Act is working. In sum, I think this is a sound budget, and I look forward to hearing from you today. And I would yield the remainder of my time to the gentlewoman from Florida, Ms. Castor.
Well, I thank the ranking member for yielding time, and I welcome Secretary Burwell. We're very excited to hear about the budget, the investments in medical research and children's health insurance, improvements in Medicare, and the Centers for Disease Control. But I couldn't help but ask Mr. Pallone for a minute to highlight the Florida enrollment numbers under the ACA. It's remarkable. And I know you've seen them, and we've talked about it. As of February 15th, Over 1.6 million Floridians have signed up for health insurance in the federally facilitated marketplace. We were surprised. This exceeded all of our expectations to beat California, in Texas, especially in a state that had many fits and starts over whether to assist our neighbors in signing up. But I wanted to highlight a couple of stories. A 27-year-old third-year law student at the University of South Florida got assistance from a navigator. His income is about $16,000 a year in scholarships. He was able to find insurance for approximately $10 per month, zero deductible. It's his second year enrolling in the marketplace. He's very happy with his coverage. There are stories like that again and again and again. So I look forward to talking about it. Thank you.
The gentlelady yields back. That concludes the oral opening statements. As usual, all the written opening statements of the members will be made a part of the record. And so we'll go now to Secretary Burwell. First of all, thank you for appearing before us today, Madam Secretary. Your written testimony will be made a part of the record. You'll be given 5 minutes to summarize your testimony, and we certainly appreciate you being here this morning, and you're recognized for 5 minutes for your summary.
Thank you, Chairman Pitts, Chairman Upton, Ranking Member Pallone, and Ranking Member Green, and members of the committee. I appreciate the invitation to be here today. I want to thank you for the opportunity to discuss the President's budget for the Department of Health and Human Services. I believe firmly that we all share common interests, and therefore we have a number of opportunities for common ground, from preventing and treating substance abuse to advancing the promise of precision medicine to building an innovation economy and strengthening the American middle class. The budget before you makes critical investments in healthcare, science, innovation, and human services. It maintains our responsible stewardship of the taxpayers' dollars. It strengthens our work together with the Congress to prepare our nation for key challenges both at home and abroad. For HHS, it proposes $83.8 billion in discretionary budget authority, and this is a $4.8 billion increase, which will allow our department to deliver impact today and lay a strong foundation for tomorrow. It's a fiscally responsible budget, which in tandem with accompanying legislative proposals would save taxpayers a net estimated $250 billion over the next decade. In addition, it is projected to continue slowing the growth of Medicare. It could secure $423 billion in savings as we build a smarter, healthier, better system. In terms of providing all Americans with access to quality, affordable health care, it builds upon our historic progress in reducing the number of uninsured and improving coverage for families who already have insurance. We saw a recent example of this progress with the about 11.4 million Americans who either signed up or re-enrolled in this past open enrollment. It extends CHIP for 4 years. It covers newly eligible adults in the 28 states plus D.C., which have expanded Medicaid, and it improves access to health for Native Americans. To support communities throughout the country, including underserved communities, it invests $4.2 billion in health centers and $14.12 billion to bolster our nation's health workforce. It supports more than 15,000 National Health Service Corps clinicians, serving nearly 16 million patients in high-need areas across the country. With health center mandatory funding ending in 2016, we estimate that more than 7 million Americans may lose access to essential cost-effective primary care, and this could approximately result in 40,000 jobs lost. To advance our common interest in building a better, smarter, healthier delivery system, the budget supports improvements to the way care is delivered, providers are paid, and information is distributed. On an issue for which there is bipartisan agreement, it replaces Medicare's flawed sustainable growth rate formula and supports a long-term policy solution to fix the SGR. The administration supports the type of bipartisan, bicameral efforts that the Congress took last year. To advance our shared vision for leading the world in science and innovation, it increases funding for the NIH by $1 billion to advance biomedical and behavioral research. In addition, it invests $215 million for the Precision Medicine Initiative, an effort to focus on developing treatments, diagnostics, and prevention strategies tailored to individual genetic characteristics. To further our common interest in providing Americans with the building blocks for success at every stage of life, this budget outlines an ambitious plan to make affordable, quality childcare available to every working class, middle class family. To keep Americans healthy, the budget strengthens our public health infrastructure with $975 million for domestic and international preparedness, including critical funds to the global health security agenda. The budget will support CDC's critical infrastructure and cross-cutting research to facilitate rapid response to public health emergencies and other public health threats, like the recent measles outbreak. It also invests in behavioral health sciences and substance use prevention. Finally, as we look to leave our department stronger, the budget invests in our shared priorities of cracking down on waste, fraud, and abuse initiatives and are projected to yield $22 billion in gross savings for Medicare. We're also addressing our Medicare appeals backlog with a variety of approaches, and we're investing in cybersecurity. As I close, I want to make one final point, and that is I am personally committed to responding quickly and thoughtfully to the concerns of Congress and members. Since I was confirmed, I've made it a top priority of our department to respond promptly and thoroughly and work with you as we can. I also just want to take one moment to thank the HHS employees for all their work on Ebola, unaccompanied children, and all the other issues. With that, I look forward to your questions. Thank you.
Thank you, Madam Secretary. I will begin the questioning and recognize myself 5 minutes for that purpose. Let me start with King v. Burwell. In a few short days, the Supreme Court will be hearing oral arguments in the King v. Burwell case that could have a major impact on Obamacare. In January, we sent you a letter asking for any actions, analysis, or contingency plans that HHS has undertaken to prepare if the IRS rule is overturned. And while we received a letter from you earlier this week, your response failed to actually answer our question. The letter simply stated that you believe no administrative action by HHS could reverse the effects of a decision in favor of the plaintiffs. Madam Secretary, your statement of opinion in the letter does not answer our simple question, so let me ask you the question this way. Have you or senior department officials instructed counselors within HHS to prepare any potential actions or approaches if the Supreme Court rules against the IRS?
Mr. Pitts and Mr. Chairman, with regard to what is in the letter, one of the things that I think is important to reflect that is in the letter is the analysis of what would happen. That is a part of the letter. And in terms of what would happen, and I first should state, we believe that the court will decide in favor of the position we hold, which is we believe that this law says that people, I've traveled across the country, people in Texas should have the same subsidies in people in New York. So important starting point. But with regard to what would happen, because I think that's an important part of answering the question. First, what would happen is when those subsidies go away, 11.4 million people, that was the number I gave you. As of January 30th, when we did our most recent analysis, 87% of the individuals in the marketplace are eligible for subsidies. Those subsidies are, on average, estimated to be $268 per individual per month. Those subsidies, number one, would go away. Yeah. That would lead to a number.
Madam Secretary, I understand that. I'm asking if you know of any plan to respond to approaches if the Supreme Court rules against the IRS. Has the White House, has OMB or other administration officials directed or asked you about any approaches in response to King v. Burwell or to work with the Treasury Department on potential responses? That's my question.
So in order to respond to the question, Mr. Chairman, in order to think about the question of a plan, one needs to, I think, analyze the problem, which is what I was articulating in terms of the three major things that would occur if the court decides with the plaintiffs.
Let me ask it a different way. I would like to provide you some more information as why we expect you an answer from you today. The committee received recently specific information from a source within your department about the existence of an approximately 100-page document related to potential actions HHS may take if the Supreme Court rules against the administration in King v. Burwell. Are you or senior staff at HHS aware of this document?
Mr. Chairman, this is a document I am not aware of. With
Okay.
regard to the question that you have asked, as I said in the letter, we believe, and I think it's very important to understand the damage because it is related to the answer. The damage comes in the number of uninsured that would occur. Number two, it occurs in what happens in the individual marketplace where a group of less healthy individuals come in and that drives premiums up in that marketplace. And number three, the indigent care that occurs from the uninsured and what that means in both those states in terms of their economies as well as what it means for employer base. Those are the ramifications. With regard to those things which we believe are the damage, as I state in the letter, we believe we do not have any administrative actions and therefore there is not.
All right, let me ask, going to another issue. As you know, as we discussed over the phone, I'm deeply concerned about the lack of HHS action regarding California and the DMHC authority to immediately include coverage for abortion. And this mandate, California mandate's a clear violation of the Weldon Amendment, which provides civil rights protections and prohibits funding to government entities discriminating against healthcare entities for following their conscience. Do you agree that the Weldon Amendment prohibits funding for states that mandate abortion coverage in insurance plans?
We take the Weldon Amendment very seriously, and since you spoke with me, Mr. Chairman, and we received those letters, we have opened an investigation in the Office of Civil Rights at HHS to investigate the concerns that you and others have articulated. We take this seriously and are trying to move through that investigation as expeditiously as possible to get
Since it's clear that California is in violation of federal law, can you project a date by which you expect the violation to be stopped?
With regard to the issue of the investigation, Mr. Chairman, that's not something I need to let the investigation go, and I have asked the team to make sure they do it as expeditiously as possible, but in order that I stay away from the investigation in terms of my interference in any way, I want to let them go forward, but I have asked for due speed.
Okay, we'll follow up. Thank you. Chair recognizes the ranking member, Mr. Green, 5 minutes for question.
Thank you, Mr. Chairman. Madam Secretary, it's been almost 5 years since the Affordable Care Act was passed, and I've yet to see any legislation introduced by my Republican colleagues to replace the Affordable Care Act, even though we've had at least 56 votes on the House floor to repeal it. Given all this talk of repealing the Affordable Care Act, are you aware of any requests for technical assistance from Republicans on legislation that would replace the Affordable Care Act with a credible proposal to provide comprehensive health coverage to millions of Americans?
I am not aware of those requests.
Madam Secretary, over the last couple of days, we've heard a lot about contingency plans. If the millions of Americans who receive financial help through the Affordable Care Act would lose them, are you aware of any Republican legislative proposals that would provide millions of Americans with the financial assistance to help them with affordable health care coverage?
I am not aware.
Secretary, I want to get your input on an issue that I know you're concerned. I appreciate you addressing in your opening remarks that myself and a lot of members of our committee, there's a funding cliff that's facing our community health centers. Health centers serve nearly 22 million patients and are projected to serve 28.6 million patients in over 9,000 locations across the country in the fiscal year of 2016. Because of the current patient demographics and statutory mandate to locate in underserved areas or to serve underserved populations, health centers are well positioned to provide health care service to millions of newly insured Americans. They're particularly important in our district, which is a federally designated underserved community in Houston, Texas. Secretary Burwell, I was pleased to see the President's budget included multi-year extension of mandatory funding for health centers. As you know, the health centers' patients face a major loss of access in a few months if we don't act or to prevent the funding cliff caused by the expiration of the mandatory funding at the end of the fiscal year. Can you speak about the importance of community health centers within our health system as we look at the issues of access, quality, and cost?
We believe that they are a fundamental underpinning, and not just in terms of health care in communities, but they are also an important part of the economics of communities when you think about the fact that we could lose up to 40,000 estimated jobs in terms of if we don't extend. But as you think about the numbers, thinking that 1 in 15 Americans actually are served by these health centers, how integral they are to providing primary care throughout the country. And so we think it's extremely important to continue that so that we can, as we have reduced the number of uninsured, we also want to make sure that those people are having care, and those that had care before still have access to that care, especially in our underserved communities across the country, not all, but many of which are very rural.
Can you comment on the impact that the funding cuts would have on patients' access to care? Can you estimate how many fewer people would be able to receive services at our local health centers?
Our estimates are that if we aren't able to extend, that it could be up to 7 million patients who would no longer be able to have access to that care. We estimate that perhaps over 2,000 of the centers would shut down without that, and then there are the patients who would not be served because people would have to scale back in a number of the centers with reduced funding.
In those 2,000 centers, do you know how many jobs would be lost?
Approximately, the estimates are up to 40,000.
Okay. Thank you. The health centers are a crucial part of our nation's primary care infrastructure for 50 years and have long had a truly bipartisan support. And last year, along with my colleagues on both sides, including Representative Lance, support for reiterating our support for health centers and calling for a bipartisan solution. We had 250 co-signers, including 31 members of our committee. Similarly, there in the Senate gained 66 votes, and more than 100 national organizations have called for a fix. Consensus is something that must be done, and we have to act as soon as possible. This issue is a top priority of mine, and I know a lot of other members, literally Republican and Democrat across the country, who look forward to working with you and our colleagues on the committee on a bipartisan basis to find a solution to avert that funding cliff. Mr. Chairman, I have 43 seconds left, and I'd like to yield for somebody for that 43 seconds on our side. Anybody want about 30 seconds now? Okay. Well, Mr. Chairman, I yield back.
Thank you. Chair now recognizes the chairman of the full committee, Mr. Upton, 5 minutes for questions.
Thank you again, Mr. Chairman. Secretary Burwell, there are a number of health care law implementation issues that continue to trouble us. In the interest of time, I'd ask that you submit answers to the following questions in writing within 2 weeks. The CEO of healthcare.gov recently stated that there is a 2-year development plan for the back end of the healthcare.gov. If you could provide us an estimate of when the back end will finally be fully automated, would be great. Second one is HHS recently announced that 800,000 Americans enrolled in coverage through healthcare.gov received inaccurate tax forms under the ACA. We'd like a detailed assessment on when the department expects these taxpayers will have accurate information in hand so that they can file their taxes. And third, many Americans were automatically re-enrolled in exchange plans, raising concerns that individuals and families may be getting unexpected premium bills or inaccurate exchange subsidies in 2015. We would ask that you submit specific data on the number of Americans who've been automatically re-enrolled in those exchange plans. So that would be helpful.
Yeah, happy to.
Now I'll return to 21st Century Cures, and again, appreciate your personal assistance with this. And I, for the record, want to certainly thank Dr. Collins, Commissioner Hamburg, Dr. Woodcock, and Dr. Shuren, countless others at your department for the help on 21st Century Cures. Because of that participation and participation of folks from across the country, we've been able to learn more about the status of innovation in this country, and we hear about ways to accelerate the discovery, development, delivery of cures and treatments for patients. As we heard at our first roundtable, there are over 10,000 diseases, and we have only cures and treatments for about 500. So we have a great deal of work ahead to do. We released a discussion document last month and have been working with Congresswoman DeGette, Mr. Ranking Member Pallone, Mr. Green, other members of our committee on both sides of the aisle to improve that document. One area that includes a placeholder is precision medicine, something that the President talked about in the State of the Union address and subsequently a White House event a couple weeks ago. We did put that placeholder into the draft, and we look forward to continuing to work with you and the White House, the administration, on that important issue. Could you give us some background on the administration's precision medicine policy and what we should look forward to?
Thank you, and thank you for the partnership as we work through these issues together, and it's exciting to have the energy around these issues, including the precision medicine, which is, I think, a subset of the broader issues you're looking at. Our precision medicine initiative is $215 million with regard to, as we think about it from a budget perspective, but I think thinking about it from the pieces and what it's doing. One part of the initiative is creating a very large database of 1 million people through NIH, but we'll access that through other channels so that we're drawing from existing databases to get the information we need, because as we're talking about what this is, precision medicine or personalized medicine is getting the information so that we can do treatments that are to the individual. I was at NIH recently, had the opportunity to both see the tumors and meet the cancer patient of a kidney cancer patient, where he had had a group of tumors removed, they came back. But then using precision medicine, which meant looking specifically at the genetic makeup of his tumors that could be treated in a different way. I met him, that happened months ago, and now the patient was there discussing with me and is in a very different place. So one, that large database. Two, specifically focusing in the area of cancer, because we already are seeing some progress there, and we believe that place is right for it. The other thing we need to do is FDA, make sure that as we think about precision medicine, we regulate and think about how to approve these things in ways of a different type of medicine. And then finally, we need the health records, the Office of National Coordinator for Health, Electronic Health Records, to be a part of making sure this will do with payments and how clinicians will use. Those are the elements.
Well, I just want to say that's very helpful, and we're excited as well. And though I've been out to the NIH a number of times in the past number of years, I want to remind members here that we have got a committee trip. We've invited, I think, all the members on this subcommittee to go out to the NIH next Monday morning. Dr. Collins has been very interested in having us out to kick the tires like you saw yourself. And I know that because we have votes tomorrow, Friday, and again on Monday, and perhaps over the weekend, there may be more of us here over the weekend than originally thought. So I want to remind members that they're invited to join with us and not miss votes come Monday on a trip there, and I yield back. Thank you very much.
Chair, thanks, gentlemen. Now recognize the ranking member of the full committee, Mr. Pallone, 5 minutes for questions.
Secretary Burwell, I'm sure you can sense that I'm very proud of the Affordable Care Act and concerned about Republican efforts to repeal it or now take it to court in the case of King versus Burwell. Are you aware of any Republican bill that would reduce the number of uninsured in this country by 11 million people? I said 11, it's actually 19 million people, the way that the Affordable Care Act does. I mean, obviously I'm saying this because I don't see them coming up with any alternative.
You know, we haven't, and I think it's important to reflect historically. When one looks at the history, and actually I've gone back to Teddy Roosevelt and the quotations from Teddy Roosevelt forward through both Republican and Democratic administrations, we see whether it was President Bush, President Nixon, Republican and Democrat, President Clinton, the conversation about how we make this next step forward with regard to reducing uninsured is something that we've struggled with as a nation. And this is the first time, and someone reflected on the anniversary of Medicare and Medicare, and that 50-year anniversary, this is the first time that we have seen that. And so the plan that we have in place, the implementation of the Affordable Care Act has done that, but we have not seen any alternatives.
All right, let me issue about CHIP. All the Democrats on the committee recently introduced a bill to extend the CHIP program, and I want to emphasize again that we have to act on this legislation immediately when we consider SGR, which expires at the end of March. While funding may not expire until the end of September for CHIP, in fact, 20 states will finish their legislative sessions by the end of April, and more than half by June 1st. So it's clear that Congress needs to act swiftly to ensure states can budget appropriately for CHIP and to avoid any disruption in children's coverage. So given the bipartisan history of this program, I see no reason why Congress can't act very soon. Can you comment on the impact on states if the CHIP funding isn't extended soon?
I would comment on that from two different perspectives. One is a former director of OMB, and the issues of predictability of funding and the issues of management and ability to manage. And so for the states to be able to do that, this is something that's important. When we've had predictability in our own budget system, we've seen the benefits of that economically throughout the past years. 2 years. And the other thing I would say is, having just spent a lot of time with the governors this weekend when they were in town, this is a very important issue to them. We have seen that letter that 40 governors have signed with regard to knowing that they have that predictability of a program that is providing great benefits to the children in their states.
Now, the Senate and House Republicans have released a CHIP proposal this week. However, this proposal would institute a 12-month waiting period, needlessly forces low-income children off of Medicaid and onto CHIP, and reduces or completely discontinues coverage for children above 250% of the federal poverty level, despite the choice of 28 states around our nation to cover those kids. Can you discuss the impact of policies like this on some of our most vulnerable children?
So we think that the CHIP program is a program that was a bipartisan program, and a program that is working and delivering results in terms of that quality health care for those children, and has worked. We believe that, as is in our budget, a 4-year extension of the program is a very important thing, and that we need to do that in a timely fashion to both make sure those children are covered and receive the care that they need, but also, in addition, to have that predictability for states, especially those states that are in their legislative process right now.
And I know you mentioned the 4-year extension. The budget includes a 4-year extension of the CHIP program. Can you talk about why that full extension of 4 years is so critical for the kids that depend on this health coverage? And maybe also mention, as part of the extension, the budget includes a permanent extension of express lane eligibility. If you talk about the success of express lane eligibility as an option for states.
So the express lane eligibility and those issues, folks ask us to try and figure out ways to simplify, to make things easier, and that's making things easier in 2 ways. When we hear from folks, it's about both the customer in terms of when they came in, as well as the states. And we believe this is a program that's been successful in getting to that simplicity, and the simplicity often can work to create either A, better quality, or B, lower cost. And so we think that's important. With regard to the 4 years, we believe that is a good amount of time and the right amount of time for us to do this extension. There will be interaction with the Affordable Care Act. We know that, and we believe that the 4-year period is the right period for us to understand and look at that.
Thank you. Mr. Chairman, I'd like to submit for the record 2 CHIP articles. The first is an op-ed published in the New York Times this month by former Secretary Hillary Clinton and former Senator Bill Frist, discussing the long-term bipartisan history of the program and the importance of a 4-year extension. And the second article was published in the New York Times last month, shows how health coverage for children pays for itself, and all the research showing that when children have health coverage, future earnings are boosted. If I could
Without objection.
Thank you,
Ordered.
Mr. Chairman.
Chairman yields, the gentleman yields back. Chair now recognizes the Chair Emeritus of the full committee, Mr. Barton, 5 minutes of question.
Thank you, Mr. Chairman. Thank you, Madam Secretary, for being here. As I have talked to you before, there are lots of problems that we have to deal with, you in your position and the committee in our position. But there are some opportunities for bipartisanship, and one of them is a piece of legislation that we call the ACE Kids Act. The original co-sponsors are Ms. Castor of Florida, I think Ms. Eshoo of California, Mr. Green of Texas, myself on the Republican side, along with several other members of this committee on the majority side. You said in your opening statement that Medicaid is going to be about $345 billion this year, an increase, I believe, of over $16 billion. Where there's one piece of legislation we could pass on a bipartisan basis that would actually save money in Medicaid, and that's the ACE Kids Act. It creates a home for families that have medically complex children based on an anchor hospital concept with the major children's hospitals in America. I think there are about 60 of them. So if a parent has a child that's medically complex and qualifies for the program, that child gets access to the network on kind of a one-stop shop. All the specialties, all the various procedures are provided. Medicaid is billed one time. We think there are about 12 million children that would qualify the program, and we believe that it will save billions of dollars over a 10-year period. It's been introduced in the Senate, the identical bill with 3 Republican co-sponsors, 3 Democrat co-sponsors. So here's a rare piece of legislation that both sides of the aisle support. The Republican leadership supports it. Chairman Upton supports it. Chairman Pitts supports it. Does your department have a position on the bill? And if so, could you explain to the committee what that position is?
So with regard to the specific legislation, I don't think we as an administration have issued a SAP, but what I would say is all of the concepts, we agree and we welcome the opportunity. The idea that we can improve both quality and cost for these children who are very complex and who are moving state to state, and the current system doesn't afford us the opportunity, both with regard to making sure we don't have duplicative payments. We obviously do not want that from a fiscal responsibility, and we want that ease that the parent can have the child at the right place with the right care, even if it's across state lines. So I would just say we look forward to working with you, welcome the opportunity. If there are questions and ways that we can provide technical assistance and other things as part of this, we welcome that opportunity because we agree with the fundamental of what we're trying to do here and believe this is something that could improve both cost and quality.
Well, I would encourage you and your department to take a look at the bill. It's not illegal or immoral for the administration to issue a letter of support. This is one that I think with Chairman Upton and Chairman Pitts and the ranking member of the full committee and subcommittee and leadership on both sides of the aisle in the House and Senate, this bill could go. It could be a part of Chairman Upton's 21st century effort, or it could be a standalone bill. I also, in the brief time I have, want to concur with what Ranking Member Green said about community health centers. I hope we can work together in a bipartisan fashion to find an answer to keep those funded. I know there's a funding issue this year that we need to address and reauthorize the program. I have a number of those health centers in my congressional district, and they are very helpful providing indigent care. And finally, I wasn't going to ask this question, but I'm a little bit puzzled when Chairman Pitts asked you the question about this report that deals with planning in case the health exchanges at the state level under the Affordable Care Act are found to not be legal the way they're currently funded. If there was a plan and if you had seen the plan, I take you at your word that you haven't seen the plan, but don't you think it's prudent that there should be a plan? I mean, I hope I don't have a primary opponent. I hope I don't have a general election opponent, but I have a plan in case I do. I know you hope that the court upholds your position, but shouldn't the administration and your agency have a plan in case it fails?
Congressman, what we state in the letter and what we believe is if the court decides, which we don't believe they will, but if the court decides on behalf of the plaintiffs, if the Supreme Court of the United States says that the subsidies are not available to the people of Texas, we don't have an administrative action that we could take. So the question of having a plan, we don't have an administrative action that we believe can undo the damage. And that's why when I was answering the chairman, I think it's important to understand what the damage is, because then it comes to the question of we don't believe we have any administrative authority.
So my time's expired, but if the court strikes it down, the administration is just going to hold up your hands and say we surrender?
What we believe is we believe the law as it stands is how it should be implemented.
I understand
And
that.
with regard to when the Supreme Court speaks, if the Supreme Court speaks to this issue, we do not believe that there is an administrative authority that we have in our power to undo it. And so that's something we don't believe we have.
That's
And on the
puzzling, but
question
I
of
accept
authority.
that. Thank you, Mr. Chairman, for your courtesy in the minority for letting me have extra time.
Chair thanks the gentleman, and now recognize the gentleman from New York, Mr. Engel, 5 minutes for questions.
Thank you very much, Mr. Chairman, and welcome, Secretary Burwell. Let me piggyback on backup plan. You know, I was part of this committee. I participated in months and months of deliberations before the Affordable Health Care Act. We had weeks of markups this committee did, and not once was there mention of subsidies not being available to individuals in states that did not set up their own exchanges. I've heard a lot of complaints on the other side of the aisle about the law, but never was this issue discussed until they lost at the Supreme Court in 2012. Some of my friends sign on to amicus briefs and waste incredible time forcing votes on the full repeal of the law, yet they're upset that the administration doesn't have a backup plan should the Supreme Court ruling threaten the availability of subsidies for 8.6 million Americans. And I think it's somewhat ironic that my Republican friends are demanding that this administration fix problems that they themselves created and have shown zero interest in fixing. Should Republicans get what they want and the Supreme Court rules in favor of King, I would urge my colleagues, if that should happen, to pass legislation to ensure that Americans have continued access to affordable coverage through the federally facilitated exchange, just as Democrats intended. Next month, the Affordable Care Act will have been the law of the land for 5 years. It's not a perfect law, and there are issues that need to be changed with it. But I would like to see those issues addressed, and let's, both of us, in a bipartisan way, turn our focus on improving the law and enabling more quality coverage options for our constituents instead of trying to kill it, repeal it, take it to court, and things like that. So I just wanted to say that I'm sure that you agree with what I just said.
We look forward to moving forward, and we do want to make improvements as we can.
Thank you. And I want to use my home state of New York as a great example of what's possible when the federal government has a willing and enthusiastic partner in the affordable health care implementation. As a result of our successful exchange and Medicaid expansion, more than 2.1 million New Yorkers have quality health care coverage. Our state's uninsured rate has dropped to only 10%, and there is clear evidence we are reaching the right people too, since 88% of people who obtain coverage through the exchange reported being uninsured at the time they enrolled. So it's really working in New York. And the health insurance options available through New York State of Health are on average 50% cheaper than the comparable coverage available before the exchange was established. So I want you to know, I'm sure you know it, that the ACA is working and working well in New York, and that's why I really think it's terrible that I've been forced to take more than 50 votes to repeal some or all of this law. We should fix what's wrong, but in my state, it's really been a tremendous success.
Unfortunately, I've had the opportunity to travel the country and see the individuals. Those are the numbers in the individuals. And whether it's Laura in Florida, 26 years old, married to someone who's a truck driver who does not have coverage. She is training to be an X-ray tech. They have 2 children. They did not have insurance. She now has insurance with a premium of $41 a month. Or a woman who had MS in the state of Texas, and for 17 years, she had not had health insurance. And so how people go about, she treated her MS through the emergency room, and she has 4 children, and she works. And so when it would get bad enough, that's what she would do. And so the stories of what it means to people in terms of their financial and health security, I think the numbers are important, but it is those stories which really make this real.
And you know, Secretary Burwell, I understand that we've seen robust exchange enrollment nationwide, even in states where Republican governors refuse to set up a state exchange or expand their Medicaid programs. Isn't this true?
So the numbers, and I spoke to this yesterday when we've been able to look at the numbers, 53% of the enrollees in the marketplace this year, in the federal marketplace, are new enrollments. And so I think that is indicating the demand for the product and the need for the product.
Thank you. I want to second Mr. Pallone's positive discussions about CHIP. I've always been a strong supporter, and as of July 2014, an estimated 476,000 children were enrolled in this affordable coverage option for their care in New York, and so I think that that is really, really important. I was pleased, therefore, to see that the budget proposal for FY 2016 included funding for CHIP for the next 4 years through FY 2019. So can you elaborate on why you believe increasing tobacco taxes is a viable means for funding this program while we sort out the transition issues associated with the Affordable Care Act?
We believe one of the things in trying to be fiscally responsible and indicating how we are paying for things, we believe that this is a legitimate way to pay for things, especially in the context of we are providing health care and something that will hopefully create a deterrent and help health care in terms of the issue of a tobacco tax. As one analyzes across the department, and whether it's at CMS or CDC, the impact that tobacco has on health in our nation and the cost of health care in our nation is one that we think is a fair place to go to pay for this care for the children.
I agree with you. And finally, I want to talk about graduate medical education because I was concerned that the administration's proposal to cut indirect GME funding. 1 in 6 physicians in America obtains training in my home state of New York, and we have some of the finest academic medical centers in the country. So it requires significant funding and time to develop the infrastructure and expertise necessary to ensure quality care is available. So how do we ensure stability for these academic medical centers and the patients they serve if we put GME funding at risk?
We believe and hope that our proposal does not do that and meets the objectives of making sure we are training appropriate physicians for both primary care and specialties where we don't have as many as we should. At the same time, making sure we target it. There's $100 million for pediatric and then a wider pool for competition. It's an issue that we want to meet the same objectives. At the same time, we do it in a fiscally responsible way.
Thank you. Thank you, Mr. Chairman.
Chair, thanks, gentlemen. Now recognize the Vice Chairman of the subcommittee, Mr. Guthrie. 5 minutes for questions.
Thank you, Madam Secretary, for coming, and I really look forward to working on 21st century cures and all the things that we can work on over the next years as Vice Chair. But first, I'd like to direct your attention to the cost share reduction program contained in the ACA, specifically sections 1402 and 1412. Does any part of this budget request, or does any part of this budget that we're talking about today request any new authority, including any transfer authority to pay insurers under the cost share reduction program?
With regard to the program, which is a program, as you know, is about making sure that the cost of health care to those individuals that are coming into the marketplace is something that they can afford. That's what it's about. And we believe that we do have the authorities to do the cost sharing.
Is there any new authority requested in this budget?
No new language.
There's no new language. And so we do know it's up and running. I think we spent $3 billion already on the cost share reduction program that have been paid to insurers of taxpayer funds. The budget that's been submitted estimates $11.2 billion over 2015-2016, and CBO says $175 billion over the next 10 years is what they've estimated. And could you cite where the appropriations authority is? I said you do believe you have the authority. Can you cite where that is?
We do believe we do, and I'm sure you know that right now this is an issue that is under litigation and a court case that has been brought. And so with regard to that, that is an issue that I will let our colleagues at the Justice Department speak to because of the place it is in litigation.
But I understand that, but we're doing oversight here. I'm not an attorney. So you had, when you were at OMB in 2014, there actually was a request in the 2014 budget for direct appropriation. And that didn't happen for whatever reason, but we're spending money. So whether we spend a penny or this is a $175 billion over 10-year program. I mean, we feel like this is an oversight hearing, and so we feel like it's our responsibility to make sure to our taxpayers that we have legitimate, good answers on where this is coming from. So we're just asking for where the appropriation comes from.
I understand and appreciate the question, and I'm sorry that it is in litigation. I wish we weren't in a place where we are in litigation, but once something has entered into that place, it does create a difficult circumstance. I respect the issue of oversight, but because the litigation that has been brought by the House on this issue, we're in a place where I think that is the appropriate place for this conversation.
I'm just not aware of any pending litigation exceptions in oversight hearing questions. And is there like a legal case or authority, or did the Justice Department tell you don't have to testify?
With regard to issues that are being litigated, generally those are matters that we refer and let the Justice Department continue on.
And I'm sure you're aware that we've never been able to get an answer from the administration for where the language, nobody's ever been able to point to us where that appropriation language comes from. And you previously had requested appropriation. Let me ask you another question. Recently, you received, I think, 18 employer groups sent you a letter urging that small groups be maintained at 50 employees, and they were citing an actuarial analysis that showed when they go to 50 to 51, they use it. The actuarial analysis said that it would estimated that 2/3 of the members, so they would receive an increase, and of 18%. And I just don't believe that these small employers, 51 to 100 employees, can accept an 18% increase in their premiums. Also, the promise that if you like the plan, you can keep it, because if the 51 to 100 have to go into the new plan, they'll have to meet the requirements of the health care law, that essential benefits and the other things that have caused other people to lose their the plans that they liked if they could keep. And due to this impact, would you support allowing states to keep their market at 50 or below, not go to the 51 to 100?
This is an issue that we are looking at and examining because we have had a number of comments on it. And what I would say is I'd welcome the opportunity to see the piece of work that you're talking about and referring to, so that we can see and understand that. I think what we want to do is understand the facts around this type of thing. So I'd welcome the opportunity to see this study and piece of work that you're articulating.
Okay, my understanding has been submitted a letter from these 18 employers, but we'll make sure that that is moved forward. Well, thank you, Mr. Chairman. I yield back.
Chair, thanks, gentlemen. Now recognize the gentlelady from Illinois, Ms. Schakowsky, 5 minutes for questions.
Thank you, Mr. Chairman, and thank you, Madam Secretary, for being here today. I wanted to ask you if you are aware of any Republican legislative proposal that would keep insurance companies from denying coverage from people with pre-existing conditions like cancer, or dropping someone from coverage because they got in an accident or got sick.
I'm not aware of a piece of legislation that would take care of that issue.
So maybe I should. And are you aware of any Republican legislative proposal that would provide access to preventive services like cancer screenings, yearly wellness exams, and do that at no additional out-of-pocket cost to consumers?
I am not aware of a piece of legislation that would do that in the fulsome way that the ACA does.
Thank you. I wanted to talk a little bit about something that's a growing concern, and that's Alzheimer's disease and the costs that it is in our personal lives and also in funding. So scores of public agencies, including many HHS agencies, as well as numerous private and nonprofit organizations, are trying to address this, this challenge of preventing Alzheimer's, serving those who have dementia today, finding a cure. Shouldn't the federal government be coordinating a plan on Alzheimer's?
In terms of the issue of coordination, there is a body and an advisory group that includes both people from the federal government as well as external folks to be a part of putting together our thoughts and strategies, and it has informed the way that we are doing investments. There are members of the federal government across the government as well as external bodies that are a part of that. With regard to the work at the department, the work cuts across a number of different areas. NIH and research is generally what comes to mind for most people, but where the biggest dollars are spent is actually in CMS, and making sure that we're thinking through the issues in that space, because that's where the dollars. The other thing is the Administration for Community Living is where we work on and think about things like those that are caregivers and those that are going through that process of dementia and how they deal with it. So as a department, we work through all of those. There is this overall advisory group that we have externally and includes internal members.
So the population is aging rapidly, obviously, and Alzheimer's is taking a much bigger toll than ever on families, on healthcare systems, on people who have the disease, and the number of people living with dementia will continue to grow as baby boomers age. So you had mentioned the research that's going on. So what is HHS, NIH doing to find a cure?
So in this budget, you see a 24% increase to funding for Alzheimer's, which is much greater than the percentage increase even within the other NIH. So focusing deeply on doing that. It's also part of the BRAIN initiative as we think through their specific issues, but we are also making progress on something called tau, which is a protein that is indicative of Alzheimer's. That's one of the pieces of research that's going on, and if we can make progress there, the other piece of research is seeing if there are ways that we can slow the progression by understanding how the neural channels move and what's happening in the disease. Those are pieces of research that we're starting. We believe that with the funding we're asking for, that we can move that research, we can broaden it, and we can make it faster.
So dementia is a major focus of work in the United Kingdom and other developed countries. Are we keeping up with the rest of the world in research activities and investments?
You know, we believe that we are with regard to that, and I have been in touch with my colleagues and the secretary or the minister in the UK and continue to have those conversations. So we make sure that we are learning and staying connected to our colleagues, especially. That's a particular example where I have been in touch with Mr. Hunt and will continue to do that so that we make sure that we're learning everything we can from our colleagues, and in places where we can work together, see if we can leverage the efforts that are going on in each of our countries. And that's both across the research, the regulation, as well as the more social issues.
And who is on the Alzheimer's Advisory Committee? I'm asking that because shouldn't there be a person with Alzheimer's on the, as part of the group?
I want to get back to you directly, but it is my understanding that there is a person, that there is a slot, and that either there is or will be a person that does have, that is part of the committee. I want to get back to you on that, though, specifically.
Well, I want to thank you for the focus, and as the co-chair of the Seniors Task Force of the Democratic Caucus, I really want to work with you on that because this is a problem affecting so many families and individuals. I appreciate it and yield back.
Thank you.
Chair, thanks, gentlelady. Now recognize the gentleman from Kentucky, Mr. Whitfield. 5 minutes for question.
Thank you. Well, Secretary Burwell, I also want to thank you for being with us today, and I want to just follow up on my colleague Brett Guthrie's question. We're concerned about this cost reduction program cost sharing program, because it's $170-some billion over a number of years. And we understand that that's one of the issues involved in the lawsuit. But all we're asking you is, since you all are dispersing the money, what is your opinion as to where the appropriation is designated that you're working from?
This is an issue, as I said, I understand the question. We believe we have the authorities. With regard to the specifics of that, because we are in litigation.
But you can't tell us where the money's coming from?
With regard to having that conversation, that is what the
Were you instructed by DOJ not to answer that question?
With regard to that specific issue, that is at the root of the litigation.
Were you instructed by DOJ not to answer the question?
With regard to when there are issues of litigation like this, this is our standard.
Well, you know, yesterday we had Gina McCarthy here, and we were talking about 111D, which is before the Supreme Court right now, and she gave us her theory of why she thought she was right. We're not saying that we're right or you're right. We're simply asking, what is your theory? Where does the money come from, in your view?
That is something, as I said, why don't I work to get back to you on where we feel comfortable with regard to where the litigation is, and I'd like to come back on that.
Well, I must say, I have been impressed with your facility to use numbers. You're really tuned into the budget, responding to Mr. Pitts, responding to Mr. Green about the community health centers. I was at a Rotary Club meeting recently, and I was asked the question. They said, Congressman, can you tell us what dollar amount has been incurred by the federal government as a result of state expansion of Medicaid programs pursuant to the Affordable Care Act? Because we picked up a larger percentage of the normal cost. And I would ask you that question. I didn't know the answer, but could you tell me what is the total dollar amount incurred by the federal government by the expansion of the state Medicaid programs as a result of the Affordable Care Act?
That, in terms of the federal dollars versus the state dollars?
Yeah, just the additional dollar amount incurred by us.
Let me go back and look, because the question of being able to disaggregate whether a person came in because of expansion or were under the old rules, I think I would want to make sure that we could understand.
But you don't have a dollar amount for that?
Not, I don't know. I will check with the department if we do. The one thing that I think we do
You would
know,
think that you all would definitely know that, because that, you know, just we can all talk about the advantages and disadvantages of this program, but there is a big additional cost to the federal government, and we're simply asking, I'm asking, what is that total dollar amount incurred?
I think the question that I am not sure is how one breaks out the actual number from expansion, because when people come through.
Well, let me ask you this question. At what year does the states were encouraged to expand Medicaid, which is fine, because the federal government's picking up more of that dollar amount. But at some point in the future, the federal government's not going to be picking up those additional costs. What year is that?
What year that is we never go below, the federal government never goes below 90% of the payment of the additional. So, and that
Until
is
when?
2020. Is
2020.
And so 2016 is the year through which there's 100%.
Okay.
And in your own state.
Well, do you have any projected cost over that period of time for the federal
we do
government?
have those incorporated in our budgets, but one of the things in terms of these cost issues that I think are important in the state of Kentucky.
Okay. Well, that's okay. Listen, you can't answer the question, but I appreciate it anyway. And let me ask you this. I noticed that you all made $2.5 billion in loans on the co-ops. And Kentucky has a good co-op program as well. We sent a letter last year, and we were concerned about the solvency of some of these co-ops. And the federal government, as I said, has loaned $2.5 billion. We now see that in Iowa and Nebraska, those co-ops are in bankruptcy. Have you all done any analysis to project, are there other states that there's a chance that these co-ops will go into bankruptcy? Are you looking at that?
We are looking at the co-ops. The one thing I think it's very important to note is the cuts, the deep cuts in the funding for co-ops. When the program was originally designed and the passage of the Affordable Care Act occurred, the amount of money for the co-ops to do the loans and the loans that states like Iowa felt would have made a difference. At the end, because those monies were cut, they were cut as part of sequestration. They were cut in 12. They were cut in 11. They were cut in 13.
So are you saying the bankruptcy occurred because of sequestration?
What I am saying is that had we had more funding in order to provide the additional loans to the co-ops, it could have made a difference. With regard to the fundamental of your question, which is, are we looking at the co-ops? And there are two things that we want to do. Understand whether they are stable, and then the second is where we can provide technical assistance.
Well, those questions that you couldn't answer or were not familiar with, I do hope that you'll get back with us with those answers soon.
Be happy.
Within 7 days, if possible. Thank you.
I will
Thank
want to
you.
make sure that we will get back as quickly as.
Because I've got to be back at that Rotary Club next week.
As a neighboring state, I appreciate that.
Gentleman yields back. Chair recognizes the gentlelady from Florida, Ms. Castor, 5 minutes.
Thank you, Mr. Chairman. Madam Secretary, thank you again for, on behalf of the 1.6 million Floridians that were able to buy affordable health insurance in our exchange. I'll give you due credit and to everyone at HHS, but I think the real credit goes to our terrific navigators that were on the ground, hospitals across the state of Florida, community health centers, and family members that probably put in a good word for their sons and daughters or aunts and uncles to sign up. You probably want to give them a pat on the back yourself this morning. I encourage you to do that.
I do. I want to express appreciation. I've seen the local stakeholders and met with them across this country, and it was the communities coming together. It was individuals. It was people in the community health centers. It was, as was mentioned, it was the business people. It was everyone. When I would visit, and the hospitals would be there. Everyone would be around the table working on this issue together, and it was that kind of work. And then the individuals, the churches. I visited on Second Sunday in Texas, actually was given the opportunity to speak at one of the churches, and it was all of that coming together to give this information to people so that they could make choices and have that financial and health security.
So in Florida, we have a very competitive marketplace as well. Consumers could choose from 14 different issuers in the marketplace this year. That was up from last year where we had 11. And Florida consumers could choose from an average of 42 health plans in their county for 2015 coverage. So with 1.6 million now enrolled, it really demonstrates the high stakes involved with the Supreme Court case that the court will hear next week. I cannot imagine that the court would rule to take that away from over 1.5 million Floridians and then millions more all across the country. And just like Representative Engel said, I was here during the hearings in advance of the Affordable Care Act adoption, during the markup, during the amendment process, during negotiations with the United States Senate. Never in those discussions was there any dichotomy between a state exchange and a federal exchange and the availability of tax credits. Have you seen any evidence to the contrary in your review of the record and the case that's before the Supreme Court?
With regard, I would let the Justice Department, who has reviewed everything. But the thing that I agree with is we don't think that we just don't believe that that's what the law says or what was intended by the law either.
Yeah, and I can say straightforwardly, as a member of this committee, what the legislative intent was. And it was for those tax credits to be available to every American, no matter if they're in the state marketplace or federal marketplace. But I would say if the court rules otherwise, they are going to create chaos, and they're going to strike right at the heart of the economic security of so many of my neighbors in Florida and many Americans. I know that they will study the legislative intent, and I hope they rule the right way and we don't have to address that chaotic situation. But I think with the Affordable Care Act, the real untold story is what has happened to people who have insurance, because I can cheer on the 1.5 million Floridians that now have it, but most of my neighbors already had insurance, private insurance or Medicare, and I noticed some more good news that was announced this week for my neighbors that rely on Medicare. Just in Florida alone, Floridians have saved almost $1 billion since 2010 because of the ACA's donut hole discount. Almost 350,000 beneficiaries saw savings in 2014 to the tune of about $300 million last year. The average discount per beneficiary was $884. Then for private insurance, how come we haven't been able to get the word out on how much better an insurance policy is? A consumer can't be kicked off if they get sick. In Florida alone, over 200,000 young adults can stay on their parents' plan. Floridians have received millions of dollars in rebates because the law says you have new rights and protections, and insurance companies cannot spend that money on profits. It has to go to, it can't spend the profits on salaries and excessive profits. It has to go to health care. How come, what else can the administration do to tell this good news story?
I think we can do a better job of making sure people do know. And another area is the issue of preventative care and the importance of the fact that your childhood visits and those things are no longer require copays or cost sharing in terms of when you go in for that, or measles, an important thing I think right now and a timely thing. And so I think we need to do a better job of making sure people know about those improvements to quality.
Thank you. I yield back.
Chair, thanks, gentlelady. Now I recognize the gentleman from Illinois, Mr. Shimkus, 5 minutes for questions.
Thank you, Secretary Burwell. Well, thank you. I talked to your staff prior. I appreciate your outreach trying to call. It was a crazy day, and I talked to them before you came to the table, and I do have great respect for that. But I also want to make sure that, you know, this happy clap talk about how great health care is and Affordable Care Act is moderated by real concerns out there. Remember, the bill that passed signing the law, we had nothing to do with on the House side. It was a Senate help bill that came over to us that we passed. Right? So that's the health care law that we have today, and the language of the law is pretty clear, and I'm concerned also that the Supreme Court will rule that the federal exchanges in states are not authorized to receive subsidies, and we need to be prepared for that here, and I would hope the administration would be too. I promised 2 ladies from my congressional district that I'd mention their names. Angie Esker from Teutopolis, who is a pro-life, strong family, and she cannot buy a policy that does not have abortion coverage. And for millions of Americans, this is a really important issue. And this is an emotional, just like on the other side, you know how this debate is. Mm-hmm. And I think part of the agreement from some of my pro-life Democrats was to ensure that that option would be available. Mm-hmm. And it's just not for her. The other one is Debbie McKinney Huff from a town called Highland. She's a Democrat. Her premiums went up astronomically last year. This year, they've gone up another $2,000 with a $10,000 deductible, and she can't afford it. So for all the happy dances, there are challenges out there that we don't do our constituent service if we don't understand that there's problems that have to be resolved. There's some budget requests that I want to talk about, so I'm going to move forward, but I just put that in the record. I'm a big supporter of Medicare Advantage.
You know, I was here when we passed it. Seniors didn't have any prescription drug coverage. It's been very successful. It's very popular. The budget request makes a reduction again in that, where the enrollment is going up, favorables are high, and 670,000 people weren't able to access Medicaid Advantage. And if you're from rural parts of this country, that option is very limited, if not, or it doesn't exist. So I would ask that we relook at that so that seniors who want to have this option can choose that. And our concern is your budget hurts the ability for that to happen.
So with regard to the first issue, in terms of your two constituents, want to make sure we understand that. On the issue of the question of abortion and that
Well,
we have put in
let's
place-
just answer this question, because I got two more on budget that I need to address.
Focus on the Medicare Advantage issue.
Thank you.
With regard to that, we want to make sure the program during the period of changes that we have had, we've seen a large increase in the number of people in Medicare Advantage plans. I want to understand your 670 because 99% of beneficiaries have access to MA plans, and there may be something, and so I'd like to understand that 670 better. The third thing is that we know that those number of plans quality that have gone from 4 stars, gone to the higher ratings. We've gone for 67% in the 2 highest rating categories, 17% to 67%. So we're improving quality. More people are coming in the system, and there is premium control. So I want to understand the 670. We want to make sure and are listening. We alter our plans as we hear concerns. That's why I want to understand that 670, because we believe that we can continue making these changes. It comes back to some of the points the Chairman raised with regard to deficits and making sure that we're being responsible. MedPAC and the GAO have recommended that there is upcoding, and we need to work on it.
Okay, thank you. Are you aware of any efforts by FDA to accelerate the next round of user fee negotiations? And our concern is, if they are, and they're not doing due diligence about the fees and the return on investment, we would hope that they would not accelerate it until due diligence is done. And the last thing I wanted to address was the Biologics Price Competition and Innovation Act. Stakeholders have to be involved in that. And that's really part of this 21st Century Cures debate, not just having bureaucrats or panels, but bring in patients, bring in physicians, bring in the like, and our concern is that's not happening on this, on the Biologics Price Competition and Innovation Act and those concerns. So if you take that for suggestions, and if you want to come back and follow up on a lot of these issues, we'd be happy to talk with you. Again, I do appreciate you reaching out personally, and I look forward to working with you.
And do appreciate this issue of stakeholder input. We think it's important to making sure we get this right.
Thank you very much.
Chair, thanks, gentlemen. Chair now recognizes the gentlelady from California, Ms. Matsui, for 5 minutes for questions.
Thank you, Mr. Chairman. Secretary Burwell, thank you for being here. I want to talk about mental health. When we think about health, we need to consider the whole person. Mental health has historically taken a backseat to physical health, but the head is connected to the body and one affects the other. I've been working for years with my colleagues on both sides of the aisle and both sides of the Capitol to make changes that fix our broken mental health system. And as you know, a demonstration project based on the Excellence in Mental Health Act that I co-authored with my colleague here, Congressman Lance, into law last year. And I look forward to working with you as and the administration to make sure this is implemented properly and in a way that states can demonstrate success. I also look forward to working with you to make further changes that improve our mental health system. I was pleased to see that the budget will eliminate Medicare's 190-day mental health services more in line and keep that more in line with the physical, for which no limit exists. Can you briefly talk about that policy and how it will benefit seniors and people with disabilities who need psychiatric services?
Our overall approach in the mental health space, and it's one that we consider a priority, is to try and get us in terms of both care and payment to parity with how we think about other health issues. And there are steps that we're taking throughout the budget, and whether it's the implementation of the piece of legislation that you referred to, and the issue that your colleague just raised about stakeholder engagement and making sure we're getting that input as we implement. So we're implementing and thinking about the policies to promote behavioral and mental health through our payment system and making sure that there is parity. That seems to be something that's been important. We're trying to focus on access, because many people, the question of access to the right types of providers in terms of behavioral health, that's something you see in some of our Now is the Time budgeting work in terms of making sure that SAMHSA and others are ensuring that we have providers. And then there's access, and that's an issue for all people of all ages, but especially young people getting the access that they need. So as we think about all the pieces working together, about the funding, about the access, and then that there are providers that can provide.
I appreciate that, and as we move forward, there is a continuum of mental health issues that we need to address, and it's a complicated issue, and we certainly would like to work with you as we move forward on that. And now I'd like to also talk about seniors, because that's a special interest area of mine too. And as we consider changes to the Medicare program, our first priority should always be seniors, especially knowing that seniors spend about 14% of their household income on health care costs compared to 5% households who do not have a Medicare beneficiary. And we need to find ways to save money in the Medicare program, and we have been, but not by cutting benefits, but by realigning incentives to improve outcomes and patient care. If a senior gets the right care at the right time, it's not only better for the senior, but also saves the system a lot of money. Now, I appreciate some of the provisions in the budget, and I'd like to discuss these further with you. The budget seeks to save money by restoring drug rebates for the dual-eligible population of Medicare. Secretary Burwell, can you please elaborate on that?
In terms of the dual-eligible policy?
Yes, right. The drug rebates for dual-eligible population.
One of the things that the dual-eligible population has two elements to it. It is both a very complicated population because there are people who have a number of different conditions that are being treated in different ways. It's also a very expensive population. And as we work to improve both the quality and affordability of the care, that's what we're trying to do as we look at these proposals. And it's all a part of the broader issue of delivery system reform, which you touched on a little bit. And we have set out clear goals. For the first time ever, we have said that in the area of Medicare, that by 2016, we have set a goal that 30% of all payments will be in different payment systems, where we are not paying for volume, but paying for value. And as a part of, we move forward to this changed system, we want to do that. That's about price, but it's also about quality. And this is a proposal that we're trying to move forward on both.
And I know that this is going to be difficult because there are areas where you have to look at the budget, but as we look at this, we have to also look at the seniors, and that's really why when we look at this, I know you seek to increase the skin in the game for Medicare beneficiaries. However, I would argue that seniors already have a lot of skin in the game in Medicare, and that additional cost sharing will not bring down costs in the program. And as you know, as they have increased costs, you look at most of them are supported by Social Security, and then that what they do is you shift over the cost to pay for their health care from Social Security. So I think it's something we really have to look at more holistically. So thank you very much for everything that you're doing.
Thank you.
You bet.
Thanks, gentlelady. Now recognizes the gentleman from Pennsylvania, Dr. Murphy, 5 minutes for questions.
Welcome here, Madam Secretary. We appreciate being here. I also want to associate myself with the comments of my friend, Ms. Matsui of California, about mental health, and look forward to working with on those things. In a related area, we've had a number of hearings here regarding mental health, and among them has been the Substance Abuse and Mental Health Service Administration. We've asked them repeatedly for information over almost a year for getting some records. Chairman Upton and I have asked for these things. We have not gotten those documents, and we're concerned about their delays. I wonder if you could help us get some assurance that we'll get those documents from SAMHSA.
As you and I had the opportunity to discuss, this is something that we are working on, and I'm hopeful that very soon you'll have some of those documents, and we'll continue to work with you on it.
Thank you. I appreciate your teamwork on this. On another question, when we passed the SGR patch, I think it was last year, there was also a demo project, which is what Ms. Matsui was also referring to, for certified community behavioral health clinics to improve access. Now, as part of this, we also attached something for AOT, assisted outpatient treatment, for counties and communities to also have access to some grants to facilitate that, as long as they also were, so those community behavioral health clinics could get those to also help for those who are cycling through with histories of violence, prison, homelessness, et cetera. That small 1 percent of 1% who are persistent chronically mentally ill and going through the system. One of the things I want to make sure and find out from you is the way this was designed is to make sure that only those counties that really have AOT would be eligible for those grant programs if they're going to attach those to those community health centers. Is that something you're aware of, and can you work with us to make sure that those grant programs are available in that sense?
We do want to work with you on that, and yes, we are working on that and would like to work with you to make sure that we do have those standards in place.
Thank you. Another one has to do with a program that was discussed by SAMHSA, which is called iCare, which is to help with those going into emergency rooms to deal with those in crisis. One of the concerns I have, and certainly we've seen headlines, some tragic, sad cases such as that with Virginia Senator Craig Deeds' son Gus. The problem is that there are thousands of times this occurs in this country every year where there just simply aren't enough psychiatric hospital beds. And so people languish in emergency rooms, often in a 5-point tie down and given chemical sedatives until a room opens up. It could be hours or days or weeks in some cases. We wouldn't have this problem if we had more psych beds. And so I'm hoping that since the demand for psychiatric beds exceeds the current supply of inpatient psychiatric beds, that's something else you can work with us in legislation to say we ought to have a place for those in crisis to get stabilized, not go to jail, not sit in a jail cell and languish there, or sit in an emergency room, but work with us on that. Would you be willing to work with us on that too?
Yes, look
Thank
forward
you.
to that.
And another issue then related to the assisted outpatient treatment grant program is a standalone thing. I want to show you, I think I have a poster here of, I just want to show you some of the outcome measures. This comes out of a Duke University study. When you have assisted outpatient treatment, so working with someone from the courts or judge, working with a person saying you need to stay in treatment for a number of months, outpatient treatment, not inpatient, take your medication, see this person to report back, like with a mental health court or something. They saw an 87% reduction in incarcerations, an 83% reduction in arrest, 77% reduction in psychiatric inpatient hospitalizations, and a 33% reduction in ER hospitalizations. So I just want to show you that too. And by the way, costs are cut in half for these folks too. But it is one that, in working at the issues of CBO scoring, et cetera, we're really going to have to, I think, team up together in this and say there ought to be some options for people to be in outpatient care. And this is psychiatry, psychology, peer support, social workers, people helping with job training, housing, all those things together. But there has to be this coordination of programs. You'll work with us on this too?
Will, and I think it's part of the broader issue of delivery system reform and how we deliver quality. You're focused in a very important area in mental health. When we look at diabetes in the clinics that I've visited across the country, when we get these adherence numbers up, and people participating, and that usually has to do with coordinated care, the type of interaction and communication you're talking about. We get adherence, we get less of the disease or problem, and we get lower costs because the things that happen when we have the bad things that go wrong when people aren't adhering.
Yes, it's going to require that different view of things. And I think you may be familiar with the hearing we had in the Oversight Committee 2 weeks ago, where a GAO report identified, I was amazed by this, 112 federal agencies and programs scattered across 8 departments that deal with mental illness. They said the interagency coordination of programs supporting individuals with serious mental illness is lacking. It was really, to me, a really dizzying and sad description of the process here. I hope you'll also work with us as we work to coordinate those programs. And can I have that assurance from you as well?
We will, and we do coordinate. We coordinate them across the overarching issue and then within their areas like veterans homelessness and the issues that relate. And so I want to have the conversation about how we think about where we can strengthen those things.
Thank you. Let's continue to work with that. Thank you, Mr. Chairman. I yield back.
Chair, thanks, gentlemen. Now I recognize the gentleman from Oregon, Mr. Schrader, 5 minutes for questions.
Thank you, Mr. Chairman. Thank you for being here, Madam Secretary.
Thank you.
Last year, healthcare spending grew at the slowest rate on record since 1960. Healthcare price inflation is at its lowest rate in 50 years. You know, the ACA's gotten a lot of attribution by CBO for making a big difference in that result. Have you seen a Republican legislative language that would give us that same result?
We haven't seen a proposal that would continue us on our path with regard to some of the changes we've put in place.
Seniors have also benefited dramatically from the ACA. Prescription drug costs are a big issue for them. 8 million, over 8 million seniors have actually benefited from and saved over $11 billion, as I understand it, on prescription drugs since the enactment of the ACA. Is there a Republican proposal out there that does a similar thing?
We haven't seen a proposal about that would take care of this issue of the donut hole. And actually on Tuesday, we actually were able to update our numbers in that space, and it is now $15 billion in terms of the savings. And on average in the country, that's about $1,600 per seat.
I find that ironic that my colleagues on the other side of the aisle keep asking for a contingency plan from the administration on this bogus lawsuit, and yet, you know, as a firm believer in Article 1, legislative supremacy, with all due respect, Madam Secretary, I think it's our responsibility, and the majority party controls both chambers. Where the heck is their contingency plan? That's a rhetorical question, Madam Secretary. One of the things that's been really good, I think, in my state is the expansion of the Affordable Care Act into the Medicaid population, into the private sector. We've had some unqualified success. Emergency room visits are down like 21%. We've actually gotten hospital admissions, complications from diabetes alone down 9%, not to mention other diseases. COPD, chronic obstructive pulmonary disease, hospital stays down almost 50%. Are you getting any of those same type of results from other states? What?
So we are, and recently, actually, in the last 2 weeks, out of the state of Kentucky, we have seen a piece of analysis done by the University of Louisville and Deloitte, and that piece of legislation, that piece of analysis showed they did it at the beginning of the expansion, and then they did the analysis now. And what the analysis showed is that the expansion will contribute to 40,000 jobs in the state of Kentucky and will contribute to their GDP by $30 billion, and that's the period up to 2021, so that is over a period of time. But we are starting to see both the economic and job impacts as well as some of the health impacts that you were describing.
Well, contrary to popular demagoguery on right-wing radio and TV, this is a marketplace system we've set up. Federal government is a facilitator in that. The state, hopefully some of those state exchanges are a facilitator. Like everyone, I think here, we all believe in the power of marketplace competition. My own state, for instance, over the last year, instead of seeing the double-digit increases in insurance premiums on average, ours actually stayed level or decreased slightly. That, to me, is a key indicator for the working or non-working the Affordable Care Act. Our uninsured rate in Oregon went down 63%. I've had testimonials from hospitals and doctors about how people actually have health care access at this point in time. Could you talk about what you've seen nationally in increased competition?
So with regard to the issue of increased competition, we saw 25% more issuers come into the marketplace this year. Wow. And so more issuers means more plans and competition.
They wouldn't be doing this if they weren't making some money at this and the program wasn't working, Madam Secretary.
And so, and also with regard to the issue of competition, what we know is in many plans that are employer-based plans, people do not come in and shop. They just automatically re-enroll. And as you know, we had that as part of the marketplace this year. But we know that actually the majority of people came in and shopped. And that, I think, is related to the competition, and it's related to a consumer who wants to make the best choice, and that choice sometimes based on benefit, that choice sometimes based on cost, and cost has a number of different elements, whether that's premium or deductible.
Great.
So we are seeing more players come in, and we're also seeing the consumer behave in a way that's indicative that they want that competition and shopping.
I'd like to call out some kudos on the GME increase in the budget, the money you put in for Medicare appeals back home. We do a lot of work, of course, with people that are having trouble navigating the system big time, and the investment in primary care docs. I think that's important. Quick little comment. The only thing I'm a little concerned about is if we're going for bundle payments and increased competition, why we're hammering on the Medicare Advantage plans a little bit.
As I mentioned to your colleague, I think what we're trying to do is balance making sure that those plans are good and strong, and we've seen that over the period of the changes we've done. We try and do the changes in a measured way that gets to things that actually have to do with what we believe is strong representation of the taxpayer in terms of places where we believe there are issues like upcoding that is occurring, and that MedPAC has articulated those and others. We always want to listen and hear, and we want to watch carefully if we're seeing problems that occur with the changes. But to date, we haven't.
Thank you, and I yield back.
Chair, thanks, gentlemen. Now recognize the gentleman from New Jersey, Mr. Lance, 5 minutes for questions.
Thank you, Mr. Chairman. Madam Secretary, regarding King versus Burwell, I understand what you have said, that there can be no administrative action should the plaintiff win the case. You have stated that explicitly and repeatedly, and that is not my question. My question relates back to the chairman, who said in his opening line of questioning that we have a specific source within your department, that there is a document related to what HHS might do should the Supreme Court rule against the administration. I understand that your point of view is that there can be no administrative action. You have stated that explicitly. Are you aware of any such document? And I'm not asking about your position on administrative action. I'm asking about a document in this regard.
Congressman, if there is this document and you know of it, I would certainly like to know of the document, because I don't have knowledge of a 100-page document.
I didn't say 100-page, now did I?
Sorry,
I just said a document. I don't know how many pages it is. You're not aware of any document.
What I have, as I've said, there isn't administrative action.
Yes, I don't.
There's not a plan.
I made that clear, that I understand your point of view on that. Is there a document as to a reaction from HHS should the case be won by the plaintiff in the Supreme Court?
With regard to a reaction, as I've said, because I've articulated that, I want to be careful, because I have articulated
As I
what we
have tried
believe
to be careful.
the problems with regard to the question of what will happen. We know how many people are in the marketplace, how many
Yes,
people
yes, that's
subject to
filibustering.
the
I understand that. I'm asking whether there is any document. We have a source indicating there is a document as to what might be the response from HHS.
I'm not familiar with the document you're referring to.
And let me say that a former CMS administrator, Tom Scully of, I believe, the Bush administration, has said, of course they have a document. He said, of course they have one. I think he referred to a document. They should all resign if they don't. I would hope that your department, Madam Secretary, would have some sort of contingency plan should the court rule for plaintiff. Do you believe that the suit is bogus?
With regard to the lawsuit, as I've said, what I believe is that the law is clear.
Yes, I understand that. Do you believe the suit is bogus?
That's a characterization. My point about the suit is, what I believe is that we hold the right position and that
Yes,
our position
I
is
understand
correct.
that, and it will be argued next week, and a decision will be made by the end of June. Formerly, when I asked questions about this, not from you, but regarding prior officials, there was the impression that it was a frivolous suit. Do you believe the suit is frivolous or bogus?
What I believe is that we should continue making progress for the American people on three things that the Affordable Care Act.
Yes, I'm aware of that. Do you believe the suit
Access,
is
quali-
frivolous or bogus?
May I finish, Congressman? I believe that we, as the executive branch and the legislative branch, should be working together on three things we agree with. That's affordability, access, and quality.
I agree with all
What
of
I
that.
would like, and what I would hope that we can do, is build on the progress that we have seen. And that progress is that 11.4 million people.
Reclaiming my time, do you believe that the Supreme Court is likely to rule unanimously on this decision?
As I've indicated, we believe that the court will rule in our favor.
Mm-hmm. Do you believe the suit is bogus or frivolous?
With regard to characterization, what I think is valuable is that we believe that our position is the position that will stand, and that we believe we're right, that people in the state of New Jersey should not have their subsidies taken away because they do or don't have a marketplace, when people right across the border in New York will get those subsidies.
I believe, Madam Secretary, in equal justice under law, as is inscribed across the street in the Supreme Court building. I believe this is a very serious case. I think it's closely contested. Under no circumstances do I believe that plaintiff will win 9-0. I think there are good arguments on both sides. I have read the briefs, all of the briefs. I've read the Solicitor General's brief. I've read the brief of the plaintiff. I think it's a very serious case, and you and I may disagree on the case. I respect that, and I understand that. It's frustrating to me that here in Washington there cannot be an intellectual argument as to pros and cons, and I certainly would encourage the administration to have a contingency plan and to work with us in Congress, including the Republican majority in both the House and the Senate, should the court rule for plaintiff. Thank you, Mr. Chairman.
Congressman, with regard to the question of our authorities, what you just ended with was the issue of legislation, and I want to make sure that I touch on that. As we have said all along, we are willing and look forward to working with the Congress on any legislation that would work on those three things we talked about: affordability, access, and quality, and preserves the economy and supports working middle class. That's how we'll look at legislation. We want to do that now, and we want to do that in any.
And I was part of a group that had an alternative piece of legislation that didn't see the light of day, put forth by the Tuesday Lunch Group, of whom I'm a member of that group. It was different from the Affordable Care Act, but it was an alternative piece of legislation. Of course, it didn't see the light of day in any way, shape, or form in 2009 and 2010. Thank you, Mr. Chair.
Thanks, gentlemen. Now I recognize the gentleman from Massachusetts, Mr. Kennedy, 5 minutes for questions.
Thank you. Thank you very much, Mr. Chairman. Madam Secretary, thank you very much for being here. You touched on a moment ago that legislation that you said you were eager to work with Democrats and Republicans on. Have you seen any such legislation?
With regard to legislation that would promote and move forward on those three things, the issues of making sure we're expanding that insured population, have not seen things that would work towards that.
Madam Secretary, are you aware of how many bills were passed and signed, bills were passed by the 113th Congress?
I don't know the exact number.
Give or take a few, 931, ballpark, sound about right?
That was 1.5 minutes.
Any idea on how many of those bills were signed into law? 296, sound about right? Any idea how many times in my first term in Congress we repealed all or part of the Affordable Care Act? 55 sound about right? Any idea how many times those were signed into law?
None.
Any times, are you aware of how many times we voted on some sort of replacement bill to the Affordable Care Act that we voted to repeal 55 times to provide Americans with quality, affordable access and financial assistance to access the health care that they deserve? None.
I think the number is none.
Okay. I would agree with you. So I think given all of the discussion we've had over the course of the past several hours about contingencies, about other options, and the time that I have been in Congress, over 55 times in my first term, including another time in my second term, to repeal all or part of the Affordable Care Act, and under the time that I've been here, under Republican leadership, to not have a single bill that has seen the House floor to vote on an alternative to provide quality, affordable, accessible health care to millions of Americans. I would respectfully ask, as my colleagues have, for the administration to work with Democrats and Republicans to work on any such legislation should they decide to bring that to the light of day.
And in our budget, I would just like to mention we actually do have a proposal to improve the small business provisions of the Affordable Care Act to try and both simplify and make the tax credits better for small businesses. That's feedback we've received about that, and that is something that is included in our budget.
Now, turning to a couple, I think, hopefully more substantive questions that I could get to with you, Madam Secretary. I was pleased to see that the Democratic CHIP reauthorization bill that the President's budget was included in the President's budget extended the Medicaid primary care payment increase. The rate of increase was that it was initially included in the ACA has been absolutely critical, and for the last 2 years, it's boosted payments to doctors who treat the most vulnerable populations, making access an attainable goal, not just an aspirational target. According to a recent report from the Urban Institute, however, the expiration of that payment bump at the end of last year will result in a Medicaid provider payments that are going to be cut on average of 43% and over 50% in some states. The impact on wait times could be drastic and immediate. I was hoping, Madam Secretary, you might be able to comment on the importance of parity between Medicare and Medicaid payment to our primary care providers, and when they have to choose between seeing some of our most vulnerable populations like seniors, pregnant women, and children, why would there possibly be a reimbursement discrepancy?
So I think as you're indicating why we have proposed the continuation of these payments is because we believe it is making a difference, and it's making a difference to the access and coverage that people are getting in the system. And so we've proposed it as a continuation, and we hope that that's something that the Congress will consider and support.
Thank you. The second topic that I want to touch on today, actually, my colleague, Mr. Murphy, touched on it quite extensively in his comments, but is about substance abuse and mental health. Back in Massachusetts, Madam Secretary, I see communities on the front lines of a growing and extraordinarily devastating opiate abuse crisis. And we're looking to the federal government for some support as prescription drug abuse and the number of heroin overdoses continue to mount. Madam Secretary, I was a prosecutor before I ran for office. I saw the impacts of this on a daily basis, not just in terms of addiction and people needing treatment, but in terms of property crimes, personal crimes, for folks that are looking to try to find a way to get help, but the treatment options just aren't there. There are not enough doctors, there are not enough beds, as Mr. Murphy indicated. There's not enough wraparound services, there's not enough care. And I was hoping that you might be able to touch on the importance of actually creating these incentives through Medicaid largely, which is our largest mental health provider, to actually make sure that not just another grant program, but to make sure the incentives are in place to allow that marketplace to provide that care.
So the bad news is, as you indicate, there were 259 million prescriptions for painkillers, opioids, during 2012. That's more than one per adult in the nation. That's the bad news. The good news is that I believe that there is bipartisan support for us to do something, and I believe that that's both in the executive and legislative branch here in Washington, D.C., as well as with the governors who I met with over the weekend on this issue. I think with regard to payment, it is an important place, but there are three fundamental things that we believe we need to work with the Congress and work with the governors to do. One is in terms of the prescribing. That's at the root of much of the problem. We've seen progress in states like Florida where they are watching the prescribing. The plans that states can put in place to oversee that is an important part, but we have a part two. Second is the issue of things like naloxone and access to those, which I think gets to some of the payment issues. And the third is making sure there's medical treatment. I think that was the third part of what you were mentioning. Those three elements I think is that's a basic agreed upon, and whether it's Senator Portman and Senator Wyden or Mr. Rogers, or it's across the board, there is bipartisan support because states from Massachusetts to Kentucky and West Virginia, my own home state, are suffering in devastating ways. And the one piece you didn't mention, which is the economic impact. And having come from a large employer like Walmart, what it means in terms of having an employee base that can pass a drug test.
Thank you, Madam Secretary.
Thank you.
Chair. Thanks, gentlemen. Chair will note that we've just been joined by a group of students from the Houston area. The ranking members informed me. You want to say anything, Gene?
Mr. Chairman, I'd just like to recognize a number of our chiropractic students from the Houston area and Dr. Prasad, who actually retired as the president of our chiropractic college in Pasadena, Texas. And I invited them last night because I wanted them to show how healthcare policy is made in the healthcare subcommittee. Thank you, Mr. Chairman.
Thank you. You're certainly welcome to be here. And Chair now recognizes the gentleman from Virginia, Mr. Griffith, 5 minutes for questions.
Thank you, Mr. Chairman. Appreciate that. Appreciate the students being here. We may have some disagreements today, but I will tell you that the ranking member, Mr. Green, and I worked very hard on a health care bill that was signed into law last year. So no matter what you may see today, we do get along more often than the press lets you know. All right. That being said, Madam Secretary, in response to a previous question, you indicated you weren't aware of any of the laws being signed in. I'm sitting here with the CRS report, Congressional Research Service, indicating that there are 12 bills that repealed parts of Obamacare that were in fact signed into law. You're not aware of that. Is that correct in relationship to your previous answer?
With regard to the specifics of the answer, those were repeal questions, I thought.
Yes, and this was
full
part. He said
full
or part. So you were mistaken, weren't aware of these 12 that were partially repeals.
I was referring to the issue of full repeal.
But you are aware of these?
With regard, I'd have to look and see.
Okay, and if I could just have this entered into the record, appreciate that without objection.
Ordered.
Thank you, Mr. Chair. Also, are you familiar with my H.R. 130?
Apologize, don't know what that bill is. Maybe if it's described, I might
understand. Are you it's a bill that deals with the black lung provisions of Obamacare.
I'm not familiar with that.
I appreciate that. Are you familiar with my H.R. 790, which is the Compassionate Freedom of Choice Act?
Not familiar with the specific names of the legislation.
And I appreciate that. And are you familiar with H.R. 793, which deals with preferred pharmacy networks in Part D?
Depending on a deeper description, that may.
And so the reason I ask those questions is it's been very well orchestrated today from a political standpoint. The other side of the aisle has asked you repeatedly, are you aware of Republican legislation that deals with the issues that we're dealing with related to Obamacare? I would submit to you that in some way or another, the 3 points that you pointed out, each one of those bills did. You're not intimately familiar with them, and I understand that, and I'm not blaming you, because you've been put into that unenviable position that sometimes happens where there's a difference between negative evidence and a lack of evidence. And what you presented today is a lack of evidence, and I appreciate that. That doesn't mean that these bills don't exist, just as I gave you the numbers on those three. It doesn't mean that there aren't other bills that other members have that are out there that are Republican proposals to take care of the American citizen while we are in the process of repealing Obamacare. And so you're just submitting that you are not aware of it, but there are, in fact, bills out there that may be doing that, and also further discussions behind the scenes that may be doing that you're unaware of. Isn't that correct?
Would welcome the veterans bill. There was a veterans bill that we all agreed on. The firefighters, I haven't
I'm just
seen
saying,
the
though, that
legislation.
when you say, though, in the answer to any number of members on the other side of the aisle that you aren't aware, that doesn't mean they don't exist. It just means you're not aware. Am I correct? Yes. All right, we'll move on. The President's fiscal year 2016 budget calls for $92 million for the Office of National Coordinator, ONC, for purposes including the transition to a governance approach for health information exchange. In 2012, an HHS request for information noted that congressional authorities granted to the ONC in the 2009 HITECH Act would support this governance mechanism. Madam Secretary, I hold in my hand a copy of a congressional research report dated January 7, 2015, that suggests ONC does not have the authority to support the ONC governance structure outlined in the President's budget. Don't you agree that when agencies take action, they should be supported by congressional authorization?
Not familiar with the report, would welcome seeing it. With regard to the Office of the National Coordinator, I think you know we just came out with the plan to continue moving us towards electronic medical records. We back that up with specific things. We continue to work on something that cuts across many of the issues, and whether it's...
But you would agree with the principle that there ought to be congressional authority for an agency to take action, would you not? Yes or no?
I would agree that we
yes, ma'am.
need authority.
And, Mr. Chairman, if I could also have that Congressional Research Service report placed into the record, I would appreciate it.
Without objection, so ordered.
As a part of its governance push, ONC awarded a contract to RTI to develop its Health IT Safety Center. RTI said at the time of the award that it would define the focus, functions, governance, and value of the national health IT safety content. I'm just concerned, as I pointed out a minute ago, that when you have these comments being made, and we haven't seen it yet, and the report that I just had entered into the record shows we haven't seen the final analysis of what they're going to do, but when you have comments that they're planning to work on governance and they don't have that authority, I am concerned when the experts are telling me, both legal and otherwise, that this agency is going beyond its scope of authority, that this is a problem in this administration, and that we should be careful that we have any agency moving forward without congressional authority. I'm going to ask you to work with me as we move forward on this. I'm going to follow up with some questions and some other things and ask that you work with me to make sure that the ONC does not overstep its authority granted to it in legislation by this Congress.
Would want to work with you to understand what these concerns on governance are. This is new to me, and so would like to
Yes,
understand further what the concern is.
And I appreciate that, and I yield back. Thank you, Mr. Chairman.
Chair, thanks, gentlemen. Now I recognize the gentlelady from California, Ms. Capps, 5 minutes for questions.
I thank my colleague for yielding me time, and I do have a different topic to discuss with you, Secretary Burwell, but my colleague from Texas has asked for 10 seconds.
I'll do my 10 seconds. I want to thank Congressman from Virginia, but I think the clarification is that up until Congressman Kennedy, all our statements were repeal the Affordable Care Act without an alternative. Now, there were bills that were passed, and none of us, at least I, up until Congressman Kennedy, but you know, there's no repeal and replace. There's only repeal for 56 times. And thank you for my 10 seconds.
That's why I responded to full repeal. It was...
Thank you. You know, I want to go back to the President's budget this year, which I think on the whole strikes an important balance between controlling spending and promoting public health. And these public health topics are what I want to bring to your attention. I was pleased to see that there was continued support for nursing workforce development. I believe, and I know you do too, a strong nursing workforce improves the health of our communities as well as the quality of the healthcare system. And we now have the significant challenge in our nation of caring for a growing patient population with limited resources. And I'm a nurse, so I know that we can't reach our healthcare goals without a strong healthcare workforce made up of a range of healthcare professionals. And these are the development programs, such as Title VIII, that are proven to be a solution that can help address this challenge. And so would you please discuss briefly, because I have two more topics, what this budget request does to make sure that we have a diverse healthcare workforce, well-equipped and large enough to meet our needs?
I will just be very brief,
Sure.
which is I think one of the core and anchor places that we do that is making sure that we are funding our National Health Service Corps. And the increases that we've asked for are a very important part of that across, and it's especially important because we serve that group of people. 30% are diverse in that
Yes.
group, and in the nation as a whole, the number is 10%. So we are over-indexing for that in that, and we think that's a very important
Right.
place. I'll stop. There are other things, but I want to.
Right, and because this one that I'm going to mention is near and dear to my heart, and that is the maternal, infant, and early childhood home visiting programs. Such bang for the buck that you get with this. If you've ever seen it, and as I have been part of one, it's such a proactive and preventive service. And there is an increase in commitment in this home visiting program in the budget for 2016. These are evidence-based, as you know, bipartisan programs helping to ensure that all children across the board get an opportunity to be healthy and successful. And they are so critical to improving health outcomes for both women and children and families. So my question is, how increased funding for these programs is going to address disparities and improve the health? How can we make it better?
So with regard to this issue, because I am a mother of a 5- and a 7-year-old, I have
There
lived
you
the
go.
importance of that information very recently in terms of being able to give your children what they need. And so the program that you're describing and why we think it's important to continue on the pace, it is an evidence-based program. We have seen the results in terms of reading and other analytical skills up to 12 years old in terms of the benefits. That's as far as it's been tested. And we see what that's happening when we give mothers and parents that opportunity to get the information they need in home.
Mhm.
When you go to them, it is making the difference. And so we believe this is a very important part and part of a continuum that you see in the budget. That home visiting next comes to that early child care and making sure that we fund child care so working Americans can be a part of that. And then the issues of Head Start and improving Head Start both in terms of the length of day, the time of year, and the quality that we require. So it is a continuum in terms of making sure we're taking care of those children along the way for working families and pressing ourselves to improve quality.
Right. And to build on that and the focus on children and family, this question was asked about graduate medical education, but I want to focus on Children's Hospital GME, because Children's Hospitals programs are so critical for training pediatricians, pediatric specialists, and pediatric researchers. It's less than 1% of hospitals. They train 51% of all pediatric specialists. And the Children's Hospital graduate medical education programs currently receive much less funding than other, children don't lobby. We have to do this work on their behalf. And would you explain the proposed changes to funding for Children's Hospital graduate medical education programs and what steps are being taken to ensure that we are meeting the demand for pediatric care?
We want to meet that demand, and we want to meet that demand for both primary care and the specialties where we don't necessarily have the number of practicing physicians that we need. And so the proposal that we have tries to respond to the criticisms that we received last year with our proposal, and that there's $100 million that is dedicated firmly to the children's programs. In addition to that, they are able to compete. Right now what we do is we cover the direct costs, but we don't continue to cover the indirect costs.
Thank you very much.
Chair, thanks. Thanks, gentlelady. Now recognize the gentleman from Texas, Dr. Burgess. 5 minutes for question.
Thank you, Mr. Chairman. Again, Madam Secretary, my apologies for being out of the hearing at another hearing. And I also apologize for not having the President's budget here with me this morning. But the President did outline a number of savings in the Medicare space in the presidential budget. Is that correct? Do I understand that correctly?
That is correct.
And in general, as the head of HHS, are you supportive of those proposals in the President's budget?
Yes.
Let me ask you a question then. You know that one of the things, I mean, I have just been pounding my head against the wall for 12 years on the sustainable growth rate formula. We were very close last year. We almost cracked the nut, but we didn't quite get there. But I thought we had a good proposal, and we're very close to introducing the same policy language again in this Congress. Offsets have been difficult, as everyone would expect. So let me just ask you, those savings that the President identified, those Medicare savings that the President identified in the presidential budget, do you think it would be a good idea to apply those savings toward the permanent repeal of the sustainable growth rate formula?
With regard to how we pay for it in the President's budget, we pay for it, it is within the baseline, and we include it that way. With regard to the specific question of just using our approach to the Medicare, those savings are part of a broader context. It is a budget, and we put the budget together in its entirety. We view that those savings need to be paired with other elements of the budget.
But to the extent that those savers are identified and those offsets are identified in the budget, it seems to me that would perhaps be a reasonable place to begin the discussion of what are the offsets that are used to put in place for the permanent, universal, complete, forever repeal of the sustainable growth rate formula.
First, I want to just agree with the concept that we're talking about. In my opening remarks, I specifically said that we support the bipartisan, bicameral concepts that were put forward, and so on that we agree. With regard to the question of offsets, why I started with how we do it, which is building it into the baseline, is because that's the way we believe it should be done, and that uses the balance of things that we use to pay for things in our entire budget. So in terms of where we start and what we believe that it needs to be a range of things and not simply focused on those.
Yeah, but at the same time, as you know, the difficulty with the sustainable growth rate formula is the budget baseline, and the fact that it was built in years ago and it accumulates over time is never corrected, even though a number of patches have been passed by Congress. We basically paid for this damn thing at least 1.4 times over the past 12 years. Again,
Yes.
I just want you to know that I like the fact that the President put forward cost savers in his budget. Fair warning to you that these are where I am going to go. The lack of participation in people who are willing to come forward and talk seriously about offsets leads me to go to the President's budget as the only place I can go for democratic ideas for an offset. And that is one of the critical missing piece in getting this SGR settled.
I think your colleague actually, though, mentioned, your colleague, Mr. Pallone, actually mentioned his specific idea for this when he spoke to this issue. It was OCO, and you may disagree with that, but that was in terms of contributing to the debate.
And my door is always open to Mr. Pallone, and I await his invitation. I'll be glad to come to his office. Let me ask you a question. I know you probably are tired of hearing about King versus Burwell, but I'll bring it up yet one more time since I haven't been here. It's not exhausting to me yet. And the whole concept around contingency plans, and the American Academy of Actuaries is concerned because insurance companies are supposed to disclose the data upon which they're basing their rates in May, but there could be something that changes the equation in June. So to the extent that the insurance companies are having to deal with this unsettled future, I mean, they're going to have to deal with contingency plans, are they not? Why should the department not have a contingency plan as recommended by the American Academy of Actuaries?
So with regard to things that I have authority to plan for, I will plan for. In the budget, the current budget you see in front of you, the unaccompanied children issue, one that I know is a difficult issue and that there's controversy around, we have put in monies to plan up to $60,000, have asked for a contingency fund in case, we don't believe it will, but in case the numbers, where there are places that I can plan, we will. With regard to this issue, that's why, while the letter was simple, it actually gets to the core and the fundamental. We do not believe we have administrative authorities. If the court makes a decision, and as I want to always repeat, we don't believe the court will decide this way, but if the court makes a decision that says, and rules for the plaintiff, and says that those subsidies are not available, the question of we don't believe we have an authority to undo the damage that would then occur, which is subsidies go away, individuals can no longer pay, they go off of their insurance, they become uninsured, it drives premiums up in that marketplace, They become uninsured, there's indigent care, it goes up. We don't believe that we have an authority, if the court makes that decision at that level, that we have an authority to do it, and therefore, that's why you're not hearing a plan, is because we don't have an authority.
But I think you have to agree it will change the structure of the risk pools for the insurance companies. And Mr. Chairman, for that reason, I'd like to submit the letter from the American Academy of Actuaries for the record. And I'll yield back.
And I do think, though, that is why one does see those companies filing their briefs that they have filed in the case that articulate the point you're making.
Gentleman yields back. Chair recognizes the gentleman from Maryland, Mr. Sarbanes, 5 minutes for questions.
Thank you, Mr. Chairman. Thank you, Madam Secretary. First, thank you for stepping into public service as you've done. Your tenure at OMB and now at HHS is, I think, a real service to the country. I wanted to talk about this concept of full repeal, which has been a drumbeat for years, it seems now, from the other side of the aisle, to understand the implications of a full repeal. And so I wanted to go through some of the things that were part of the ACA and ask you, and it may not be that every one of them is jeopardized by a full repeal, but I think certainly some of them are. So the ACA included a measure that would allow young people to stay on their parents' health care up to age 26, and I think upwards of 3 million younger adults have benefited from that. If there was a full repeal of the ACA, would that benefit and provision be in jeopardy?
It was part of the original act, so yes.
Then there was an effort to begin closing the donut hole on prescription drugs under the Part D program, which has bedeviled many of our seniors who kind of fall into that donut hole, often at a critical stage in terms of needing to access prescription drugs. And the ACA reform included an effort that's begun, is underway, to close that donut hole. Would that be in jeopardy if there was a full repeal?
It would, and the $15 billion in savings that those seniors have received to date would stop.
Right. Then there was terrific provisions in terms of reimbursement that benefits and reimbursement. So on the benefits side for Medicare beneficiaries, you had more preventive care being covered fully, eliminating co-payments for certain kinds of preventive care, screening for annual wellness visits, et cetera. That was part of the ACA. A full repeal, I imagine, would jeopardize that reform as well.
Yes, and we actually just were able to have the numbers, and we have seen an increase in the number of seniors that are using that preventative care, and the percentage of seniors that are using at least one preventative service continues to go up.
Excellent. We put in some enhanced payment and reimbursement for primary care physicians, recognizing that we need to make sure we're incentivizing that part of the profession in terms of getting into the pipeline, and also having the opportunity to spend more time with their patients and have there be some economic reward for that, which the patients themselves also want. I presume that would be at peril with a full repeal as well.
A full repeal would imperil.
What about the provisions that have eliminated discrimination based on pre-existing conditions? Of course, we started right out of the gate eliminating that discrimination in the case of children. Now that's been expanded more broadly, but I imagine that also would be undermined by a full repeal.
It would, and having had the chance to meet a young woman who had cancer when she was 12 years old, she first had colon cancer and then had thyroid cancer later, and now is in her 20s and was engaged but not continuing her graduate education or getting married because her focus was paying for her health care. And now the opportunity to have affordable care is, because she had a pre-existing condition, obviously, is now allowing her to go on with her life. The issues of health security are very important, but for many individuals, the financial security is as well.
Thank you for those comments. The medical loss ratio requirement that now requires insurance plans to direct more of the insurance premium dollar to care as opposed to overhead costs and so forth. That was part of the ACA, adhering to a particular standard. That would be eliminated, I would expect, in a full repeal.
In a full repeal.
Subsidies and tax credits for small businesses who want to do the right thing and provide health care coverage for their employees was part of the ACA, so small businesses would be impacted by a full repeal in terms of their ability to offer that kind of benefit to their workers. Isn't that correct?
It would take away the tax credit if it were a full repeal.
So even before we get to a discussion of the pros and cons of the health exchanges, which have now offered up coverage to millions of Americans, there's so many other reasons in addition to that that we wouldn't want to repeal the Affordable Care Act. Thank you very much for being here. I appreciate your testimony.
Thank you.
Chair thanks the gentleman. Now recognize the gentleman from Florida, Mr. Bill Ross, 5 minutes for questions.
Much for your testimony. Thanks for your appearance. Welcome. I want to talk about Medicare Advantage. According to 2012 data, there were about 145,000 seniors in my district. About 40% of them are on Medicare Advantage, a little higher than the national average. They love their plans, and they want to keep their plans. They love their benefits and their choices. Unfortunately, this administration may not love Medicare Advantage as much as my seniors. The actuarial firm of Oliver Wyman did an analysis of the proposed 2016 Medicare Advantage rate notice. Reading the report, I'm troubled to learn that it estimates that the combined impact of cuts from 2014 to 2016 will cost seniors on an average of $60 to $160 a month, or as much as $1,920 a year. Many of the seniors in my district live on a modest income, fixed incomes. Why is the administration forcing many seniors to pay more than $100 a month to keep the plan they like?
So with regard to the issue of Medicare Advantage, first I want to say we think the program is a good program. During the period when changes have been enacted, we've seen the program expand by, I think, well over 40%. We've seen the number of Medicare Advantage plans that have the top 2 ratings go from 17% to 67%, and we have seen that premiums have not been increasing in terms of the changes that we've done to date. Why we are proposing these changes is they have been recommended by MedPAC and others with regard to overcoding that's occurring, and as part of our efforts to make sure we're using the taxpayer dollar wisely, we want to promote the program, we want to keep the program healthy, but we also believe that there are opportunities for those who may be not using the system as well as they might, and that's what our changes are about, and that's what we're trying to do. Preserve and build the system, but make sure we do it in the fiscally responsible way.
Thank you, Madam Secretary. Many seniors who like the Medicare Advantage program they have are going to lose it in the following years. In fact, a recent Milliman report details a nearly 4-fold increase in the number of U.S. counties that no longer have Medicare Advantage as an option, growing from 55 counties in 2012 to 211 counties in 2015. Isn't it concerning to you that seniors are losing the ability to choose a Medicare plan that provides high quality and coordinated care? This is a very successful program, and again, this is extremely important to my constituents.
Agree that it is a very important program, and we want to make sure that it continues. Want to see the studies and the underpinning of that. The most recent numbers that I have seen are that 99% of beneficiaries have access, and so those numbers may not align with that most recent study, and want to understand what the difference in that is.
Thank you, Madam Secretary. One more question. The impact of seniors with Medicare Advantage, according to Oliver Wyman, could result in seniors losing access to their current coverage or facing higher premiums, reduced benefits, and changes to the network as a result of the cuts, the proposed cuts. When I talk with seniors in my district about Medicare Advantage, again, they believe Medicare Advantage, the model offers high-quality, coordinated care. Yet further cuts will disrupt the benefits upon which millions of seniors rely. And your agency likes to tout the so-called affordable premiums and better consumer choices under the Affordable Care Act, but when it comes to Medicare Advantage, why is the administration pursuing policies that would increase premiums and reduce choices for seniors? And again, it's very concerning.
I think the responses with regard to the issue that what we have seen with the changes we've done to date have not had the premium pressure that's described. We want to continue to watch and monitor, and also that we have seen more people enter in and the quality improve. And so that's what we've seen to date. We want to continue to work and monitor. We want the program to succeed. We want to support it, and we want to try and do it in the way that's the most fiscally responsible.
Well, thank you, Madam Secretary. I appreciate it. I'll yield back, Mr. Chairman.
Chair, thanks, gentlemen. Now recognize gentleman from California, Mr. Cardenas, 5 minutes for questions.
Thank you very much, Mr. Chairman. Appreciate the opportunity to have this public dialogue for the benefit not only of the members, but for the public as well. Preserving access to prescription drugs that work for every senior is important, I think, to everybody on this dais, and I think every person who cares about a senior in this country, which probably makes everybody. So my question has to do with what proposals in the President's budget would increase access for seniors?
With regard to the specific access for seniors, across the board on prescription drugs, I think in terms of the programs, whether that's the way we use some of the programs we've just been discussing, but I also think one of the most important things that has happened is that seniors have access to preventative services that they historically may not have. And just announced on Tuesday that what we are seeing is because the seniors have that access to those preventative services, they're increasing the use of that. I think throughout our budget, one of the things we're attempting to do is work very hard to do a delivery system reform, which means getting better quality at a better price for the nation. And I recently announced about 3 weeks ago that in the Medicare space, we're going to try and move to 30% of all Medicare payments will be in new payment models that are about improving that quality and reducing that cost. And so those are some of the areas that I think the budget focuses on this.
Now, that effort, is it likely to create an environment, individual by individual, that's likely to increase their quality of extended life versus, because when we're talking about access to preventative care, that means that if you catch something in its early stages, we all know with today's modern medicine and opportunities, you can actually thwart it or actually overcome it, versus finding something in latent stages, it might even take your life, correct?
And across the department, there are a number of investments that get to that, and whether that's the NIH investments in research or in the Center for Innovation in Medicare and Medicaid, one of the things where we have out a proposal that we're getting response to has to do with hospice and curative care and how to combine those two in a way that will maximize for the quality of the patient. And so it's throughout the budget, these issues of cost and quality are things that we focus on.
Thank you. On that note, I'd also like to add for the record, if you would allow me unanimous consent, Mr. Chairman, to submit a letter for the record from my office that lays out the issues that we're discussing at the moment.
Without objection, so ordered.
Thank you.
I keep hearing a lot from some of my colleagues about their constituents losing choices. But then again, one of the things that it's my understanding, please clarify, that when people are talking about losing choices, they may be describing policies that were in fact more expensive on the front end and perhaps didn't have minimum benefits standards to the person paying. Is that in many cases what people are describing when people are losing choices?
It can be. I would want to understand the specific example.
And that's why I say the word
Within the
maybe,
marketplace,
maybe, yes.
Within the marketplace, there are 25% more issuers, which means more choice. The essential health benefits do important things, I think, as you're reflecting, and they get to some of the issues that Mr. Murphy and Ms. Matsui on mental health, and having those benefits be clear and incorporated is extremely important. So without understanding the specific case, I think it's a little hard to know.
But there are, in fact, in some areas where certain kinds of policies are not allowed, but that is based on a new minimum standard, correct?
That is correct.
And one of the things that I've discussed with some of my constituents, my staff and some of the providers and experts that we pulled together, we registered at least over 1,000 families. And I personally tried to speak to as many of those individuals as possible. And what was sad is many of them were even scared to be there. They were thinking about this big Obamacare dragon that was going to obliterate either their finances or their health care. But what almost to a person, every person that got up from once they sat down and figured out what was available to them or what have you, had a big smile on their face, and they were very pleased and very relieved and glad they came. And in one instance, I was talking to a gentleman who was paying $60 a month. He was making $9 an hour, single income family. He had a wife and a daughter, and I met all three of them. And when he was done, he had a big smile on his face. He almost got up and left when he met me, but when he was done, he actually realized that he now was able to provide for his family without having to spend $60 a month, and now his entire family has coverage. So I think that's a perfect example of what this is, what's good in the Affordable Care Act. Thank you, Mr. Chairman. I yield back my time.
Thanks, gentlemen. Now recognize the gentleman from Indiana, Dr. Bouchon, 5 minutes for question.
Thank you, Secretary Burwell. Thanks for coming. And first of all, I want to thank you for working with Governor Mike Pence of Indiana on Healthy Indiana Plan 2.0, which will help to cover 350,000 low-income Hoosiers in a state-based program that I think has been shown historically to not only save money, but is very popular with the enrollees. So thank you very much for that work. Before I came to Congress, I was a cardiothoracic surgeon, and I treated most of my patients for many weeks after their surgery. And as you probably know, that falls under a global payment, a 90-day global surgical payment by CMS. Now CMS wants to repeal that rule and eliminate global payments for surgical services. Why?
With regard to our understanding of how the global payments are used, the reason that we want to do this is make sure that while we are promoting quality care, that we do it in a way that is most cost effective for the taxpayer. Most of the changes that we do in the Medicare space are focused on those two things and trying to balance those two things.
Okay, and has HHS or CMS looked into the administrative costs the new system will have on doctors and CMS? The reason I ask is in my practice, I'll give you some examples of how this actually will work or won't work if you do it. We would bill a global payment and for everything, including follow-up visits. And now doctors will be billing for their surgery, every hospital round that they make, every follow-up appointment, all separately. Let me finish. And not only would the medical practice have to pay employees to submit all these, what I consider excessive claims, but then CMS will have to process each claim. How can that not cost CMS more money, not less? That's my first question.
With regard to the global payment issue, and one of the things, Dr. Patrick Conway, we try and have physicians who are practicing at the table as we have these conversations, want to understand the point that you're making and how we believe. I want to look into this one in terms of a specific answer to your question.
It will be a dramatic increase. Let me tell you why. If I did an open heart surgery on a patient, I would see them in the ICU anywhere from 3 to 5 days every day, and then probably 2 to 3 follow-up appointments. That's all under a global. And so now that those numbers will be submitted as individual bills. From a surgeon's perspective, I see this as, and I think seniors should be paying attention to these comments, this is going to be a dramatic pay cut for surgeons across this country. And that's in my view, that's where any potential savings will be coming from. So as you look at this, you should really, I'd encourage you to pay attention to that, because what will happen is you're going to have to reevaluate. There's going to be a reevaluation of every code, reevaluation of every follow-up appointment. You're going to have to discern whether there's duplicative billing. For example, if I see a patient post-op in the ICU and a critical care physician has also seen my patient that day, who gets paid, who doesn't get paid? There'll be increased denials. My point is this: global payments were put in place to save money administratively, and also simplify and I think improve quality health care. And I think going backwards away from that is regressing backwards. Yes, it will save money. This will save money by dramatically cutting provider reimbursement. And if that's the intent, that's unfortunate, because what will also result is access issues for seniors for health care services, and I would argue less quality health care. And so, you know, most of these bundles are re-examined every few years by the RUC. And so, you know, the argument that overbilling is occurring, if that were to be true, then, you know, these bundles are looked at every couple of years and reevaluated. So on that subject, I would encourage you to take a really hard look at global payments. They save money. They don't cost money. The savings will be on the backs of seniors' access to health care and quality, in my opinion. The other thing is the President's budget would seek to save $20.9 billion in savings over the next 10 years by strengthening the IPAB board, a board of unelected members selected by the President to cut, in my view, to cut Medicare payments to providers. I understand the President has not yet nominated anyone to sit on the IPAB board, so it could not recommend Medicare cuts this year. So in what year under the President's budget will IPAB begin to make recommendations on Medicare costs?
In the current President's budget, IPAB would not kick in until 2019.
2019.
That's
okay.
correct.
Okay, thank you. Thank you, Mr. Chairman. I yield back.
Chair, thanks, gentlemen. Now recognize the gentleman from New York, Mr. Collins, 5 minutes for questions.
Thank you, Mr. Chairman, and thank you, Secretary, for being here today. I'm from Western New York, which is a very rural community. We have one of the highest enrollment of Medicare Advantage. I know prior to the Affordable Care Act, I would say that without a doubt one of the bright spots in the delivery of health care in the United States was Medicare Advantage. Dealt with the donut hole. It was a lot of comfort for the seniors to be able to go in, much like we do with HMOs, and great program. And yet, as was brought out earlier, and I want to get into this, it seems as though the President and the administration and HHS views Medicare Advantage with some level of disdain, in that it's the piece that keeps getting cut. And as I look through some of the data, and I'm kind of a data-driven guy, the interesting thing I found about Medicare Advantage, there's over 7 million enrollees, represents almost 30% of the Medicare population, which would indicate it works. Number two, when you look at who uses it, lower income beneficiaries have a higher enrollment in Medicare Advantage than do wealthier individuals, which means it's serving best some of the lower income populations. We've also seen that when I look at the rural plans, again, in rural America, which I represent, a higher percentage of folks from rural America are using it. So I'm just asking the question and the interesting thing too, the bad information we got today was from AHIB. They said the current 0.9%, the 0.9% cut that's coming now in the subsidy to insurance companies for Medicare Advantage is going to add another $20 a month to beneficiaries, either in higher premiums or reduced benefits. So could you speak to just the opinion of older Americans on Medicare that they are being used as the funding source for the expansion in Medicaid and all of those increased costs on the back of our seniors who've depended on this great program for all these years? A frustration level exists within that population.
Appreciate that, and as I responded to your colleague with regard to the issues of Medicare Advantage, I would say we support the program, believe the program is a good program, but also believe that our responsibility where we think there are things that are happening, whether that's upcoding or other things, that we try and take care of that. The changes that we've done, we've tried to transition those changes. We try to do those changes slowly so that we watch and monitor. We've seen an increase in the number of people in Medicare Advantage. We have seen premiums hold steady. We've seen an increase in quality. So the negative impacts that were articulated at the beginning of those proposals, we have not seen. We want to continue to monitor and make sure that we don't see some of the negative impacts that you were talking about. We value the program. We think the changes, they've been recommended by MedPAC and others. We understand the concerns, but trying to operate in a world, and with regard to the other issue that you mentioned, I would just say across the board, and whether it's the issue that your colleague just mentioned with regard to providers or the $780 million we do in discretionary cuts, we try to spread these things across the entire parts of our budget.
But are you aware that there are now over 200 counties in the United States that don't have a Medicare Advantage plan at all to offer their seniors as a direct result of the cuts you've made? So when you say it hasn't had this impact, there's seniors in over 200 counties in the United States that can't even buy the coverage.
So 99% of the nation has coverage in terms of the beneficiary's accessibility.
But yet the number who don't has increased. from 55 counties before the ACA to over 200 today. So there's a direct impact. I mean, the numbers, the data is the data. You can't make it go away.
With regard to those numbers, as I said, I have the number of the current coverage and would want to understand the change over the
Yeah,
period.
what I'm trying to point out is it has had the reason you're looking for this funding is to pay for the expansion of Medicaid. I mean, whether it's the health insurance tax or the individual mandate or whatever, the big cost driver has been this huge expansion in Medicaid, would be my observation.
What I would observe is some of the comments that have been stated about the question of overall entitlements and the growth. We have a bulge, a population. We have a large group of people who are elderly in Medicare. The Medicare costs, even though we've controlled per capita cost for Medicare over the period of what we're seeing, because more people from the baby boom are retiring and older, that's an issue that we as a nation are going to have to look at and deal with. Medicare costs are going to continue to increase because of volume, even if we can control per capita costs. And so with regard to the questions of what will be costing the nation money over periods of time, the issue of Medicare is one on because we're going to have the baby boom and the echo come through, we're going to continue to have to make good on the commitments we've made. And that will cost us, because even if you control it per capita, volume is greater.
Well, thank you for the answer. My time's expired. Yield back.
Chair, recognize the gentleman from New Mexico, Mr. Lujan, 5 minutes for questions.
Thank you very much, Mr. Chairman, and I would yield to our ranking member, Mr. Green, for a quick response as well.
Thank you, Mr. Chairman. I want to respond to my colleague from New York. I've not had any of my seniors question the expansion of Medicaid based on what's happening with Medicare. The Affordable Care Act was totally paid for, and in fact, Medicare was improved under the Affordable Care Act. And Madam Secretary, if you just, this is the first I've heard that seniors are complaining that the Medicaid expansion is being paid out of Medicare. That's just not in fact that I hear about. Do you have any information on that?
That is the first that I've heard that anyone felt that that was an issue with regard to the federal budget, because I assume that's what they're referring to.
Yeah, if the gentleman would yield 1 minute.
Thank you, reclaiming my time. Thank you, Madam Secretary, for your testimony today. I want to reiterate what many of my colleagues have said, that we must repeal the SGR, but not on the backs of seniors, and that a strong CHIP extension must be included with the SGR in March as well. Also, that the Affordable Care Act is working, despite an attempt of over 50 Republican repeal attempts. The ACA has had a positive impact on New Mexico in my home state. In my home district, 25,000 people now have quality affordable health coverage because of the Affordable Care Act that didn't before. And overall, the numbers of uninsured has declined by 17%. With the law now fully in effect, Americans can never be discriminated against because of pre-existing conditions. Women can never be charged more for coverage because of their gender. And Americans will never be sold health insurance policies that disappear when they need coverage most, when they hit those lifetime caps and suddenly coverage goes away. I think that it's time that we come together and work to strengthen the law and stop playing political games that will strip millions of Americans of the health coverage they depend on. As my father would say, enough is enough. Madam Secretary, in your opinion, has the Affordable Care Act had a positive impact on places around the country, including my home state of New Mexico?
Yes, and I think it has in 3 areas: affordability, access, and quality. With regard to the issues of quality, you touched upon a number of the areas where I believe there's been an improvement in quality. And those are the fact that people can have their children covered up to 26, the quality that you don't, if you have a pre-existing condition, you can't be kept out or thrown off of your health care. The fact if you take your child in for their wellness visit, there isn't co-insurance, so you don't have to pay. In terms of that preventative care. So increases in quality. We've also seen increases in quality through partnerships we're doing with physicians, and we've seen a 17% reduction in harms. Those are things like infections and falls in hospitals. That's also about saving lives, but it's also about money. With regard to the issue of affordability and the progress that we've made on affordability, while we can all still continue to make more, we have in that space, and what we've seen is that in the years 2011, 12, and 13, we have seen a record in terms of per capita health care cost growth. It's one of the lowest that we've seen on record, and we've seen that. That's in the broader marketplace. With regard to the individual market, what we've seen is that people, the vast majority, over 8 in 10 folks in the marketplace can find coverage using a subsidy that is $100 or less than a month. That's affordability in that marketplace. With regard to affordability and the taxpayer, CBO estimates pre the Affordable Care Act would have estimated that spending in Medicare would have been $116 billion greater. Affordability for the taxpayer. Lastly, access. The question of access and the fact that 11.4 million people have come through the marketplace this time, but let's even use last year's number where we saw a 10 million person drop in the number of uninsured. So against the three fundamental measures, that's how I would think about it.
I appreciate that, Madam Secretary. Thank you for your response there. And I do want to raise an issue that has great concern to my constituents and to myself back in New Mexico. It's now been over 18 months since the state of New Mexico claimed credible allegations of fraud, or their allegations of fraud against 15 behavioral health providers, resulting in the eventual closure or replacement by 5 Arizona behavioral health providers. This transition and turmoil has raised significant concerns across access to care, especially in light of recent reports that the new providers are financially unstable. In fact, one provider is already pulling out of New Mexico. The recently elected New Mexico Attorney General has also released the audit that led to the suspension, and it shows a lack of underlying basis for many of the allegations of fraud. My staff has had several meetings with CMS, and I'm very concerned that we are not making progress. When payment suspensions are put into place, what can CMS do to ensure states are acting in good faith? And what is the CMS doing to stop the reoccurrence of this happening both in New Mexico and other states? And can I have your commitment that we can work together on this particular issue and meet with the delegation?
Do want to work with you on this issue. No, it is one of concern in terms of making sure that people have access to those benefits.
I appreciate that. Thank you very much. I yield back the balance of my time.
Thanks, gentlemen. I recognize the gentlelady from North Carolina, Ms. Elmers, 5 minutes, President.
Thank you, and thank you, Madam Secretary, for being with us today. I'm sorry, you've got some water there? We should get you some water. I do want to address, before I ask, I have 3 different, very different questions to ask you about, but I do want to address the issue of Medicare and our seniors who are concerned. It is my recollection, and you know, there again, I'm just going back to history, that over $700 billion was taken out of Medicare in order to pay for Obamacare. About $300 billion of that was Medicare Advantage. So to the question of whether or not our seniors are concerned about that, I would say yes. They are concerned about that, and they want to make sure that they will be able to continue to get the good care that they deserve. I do want to start off by talking about Medicare reimbursement in relation to the 2% sequester cuts that were put in place a number of years ago, dramatically affecting our chemotherapy drugs and our other Part B drugs. As you know, this has affected our industry. Back in January 14th of 2013, Office of Management and Budget put out a letter basically asking federal agencies to, quote, use any available flexibility to reduce operational risks and minimize impacts of the agency's core mission and service of the American people. And it goes on. Some of the adverse things that have happened as a result of the 2% cut over 16 months after CMS started applying the 2% cut, we basically ended up with 25 community oncology clinics closing, one of which a very large clinic in my own district, and 75 others merged with hospitals. CMS own numbers show that it costs $6,500 more per year per patient on oncology services if they become part of the hospital system versus the clinic setting or outpatient setting, and about $650 more out of pocket. How can this, you know, why hasn't CMS taken the recommendation of OMB and addressed that situation?
Congresswoman, we agree with you about sequester, and in this budget, we fully get rid of sequester both on the mandatory side and on the discretionary side. We believe there are other choices that are better choices, and so agree with you. This is not an approach. When you use an approach like this, you end up doing things like the types of things you're talking about, and so what we want to do is fully replace it, and that's what our budget does. We're willing to make other choices in terms of how we get those savings.
Thank you, and I'll just go on, and this, there again, a very important question having to do essentially with our tobacco products. My question for you is, do you agree with Mitch Zeller, Director of FDA's Center for Tobacco Products, that if the smokers, and I'm going to quote him, who are otherwise unable or unwilling to quit were to completely switch to smokeless tobacco products, it would be good for the public health? Do you agree with this statement?
I would have to understand the context in which he made that statement. With regard to the question, I think we want to promote the public health. We want to make sure we're doing the right research to understand that and put in place the right guidelines and regulations to do it.
Well, thank you for that. And I do want to add there that there are no government websites that help promote or, address this issue, including CDC, FDA, NIH. It would be helpful, again, for the public to understand that there are the non-tobacco products available and that this is an approach that we need to make. And I would welcome the ability to continue to work with you and your office on any way that we can, better help to get that information out and address the needs from a scientific basis, and using the scientific research that's out there. I do want to switch gears a little bit to our vaccines and to BARDA. Right now, BARDA maintains a stockpile of roughly $1.7 billion worth of pandemic influenza vaccine. This year's budget, I believe, was about $20 million in order to take care of that stockpile and maintain it. Does the 2016 budget increase that amount? And into the future, how does BARDA plan on dealing with those issues, especially when we know that we are in our situation where this is a very timely issue?
Across the board, our budget has worked to do a couple of things with regard to the preparedness, making sure that vaccine stockpile and that the issues that BARDA handles, which are making sure that we have what we have on hand in stockpile and that we have the ability to work with manufacturers to bring new products online where that's appropriate for different types of issues that we as a nation may face, either man-made or otherwise. But we also have paired that with things in our budget which are about the preparedness in our communities, and we've seen that front and center, certainly in our Ebola time period. We are implementing the dollars we appreciate from Congress as part of that in terms of Ebola, but also broader preparedness where we have been given that authority by the Congress.
Thank you, Secretary Burwell, for being here today. I truly appreciate your input. Thank you.
Chair, thanks, gentlelady. That concludes the questions of the members who are present. I'm sure we'll have lots of follow-up and written questions from some of the members, so we'll get those to you promptly. We ask that you please respond to the questions promptly. I remind members that they have 10 business days to submit questions for the record, and that means they should submit their questions by the close of business on Thursday, March the 12th. Thank you very much, Madam Secretary, for your attendance today and your answers. Without objection, subcommittee is adjourned.